Just today is my day. I'm just joking here. That's just joking. No, why? Why are your guards down, some of you? Nandesh?
Oh, HOD only. Such a strict teacher she is.
We are all vaccinated, yeah. Hello? Yes, madam. It's the same as yesterday. I'll send it to you on your, you want it on the email. Don't send on WhatsApp. Okay. Yes, yes. Sure, sure. Yes, ma'am. I'll send it right to you. Yeah, yeah. No, yesterday, whatever you logged in, ma'am, same notes. Shall I send it?
Oh, yeah.
Hello, madam.
Hello, good evening or good afternoon rather. Hi, Shankar.
Madam. Good afternoon, Dr. Sundaram. Good afternoon, madam.
Good afternoon. Good
Good
afternoon.
afternoon, sir. Dr. Sarla, madam. Hello.
Oh, yeah, she's very
Sarala, hello. Sundaram. Hi.
Original muscle.
All muscle. Muscle group. But not muscular.
Someone's in full josh.
I know. Same ತಗೊಂಡ್ರಿ ಮಧ್ಯಾಹ್ನ. I hope you're muted, yeah? Sarla madam is like, she's through the eye one eye. You can see.
Sitting there itself is both of them is very difficult. So inspiring to see that they are there.
I think one of my relatives, she was saying, I have to talk to my father on this. We take once around your mind.
So 3:30, yeah? It comes to 3:30. Should we start? Should we wait another 5 minutes?
They have to log in, right?
It's exactly 3, so should we give 5 minutes?
A very good afternoon, good evening, and namaste to all of you. I am Dr. Nandish, Associate Professor in the Department of Neuropathology, MATS, and I have been vested with this great opportunity of comparing this MYOLOGY symposium, organized by the Department of Neuropathology, MATS. This symposium has been organized as a respect, honor, recognition, and as a token of gratitude to a very dedicated, duty-bound, highly committed and accomplished academician, researcher, and mentor who has shaped the destiny of many students, including myself. I now request our professor-elect, Dr. Esha, to welcome the audience and introduce the symposium.
Warm greetings to all our invited speakers from across the globe, chairpersons and participants. A special welcome to our senior teachers and colleagues who have joined us today for the MYOLOGY Symposium to felicitate Professor Gayathri. It is my pleasure to say a few words about Dr. Gayathri, though she needs no formal introduction to this audience. Dr. Gayathri is a keen scientist, blending both research and diagnostic work seamlessly, an enthusiastic teacher and a very warm person. A renowned myopathologist and specialist in electron microscopy, she began her career in NIMHANS as a research assistant under Dr. Sarla Das, fresh after her master's in zoology. This initiated her enduring interest in myopathology, leading to her doctorate degree under Professor Sarla Das and Professor M. Gauri Devi, who are here with us today. As a scientific officer in electron microscopy lab, she developed her other lasting love for electron microscopy under the expert tutelage of late Professor Y. Ram Mohan. She joined soon after as a faculty in the Department of Neuropathology and is now superannuating this month end after 38 years of service at NIMHANS. A big hand to her. Her contributions have been immense and pioneering in many ways. Nevertheless, I will try to summarize them briefly. She was instrumental in standardizing and setting up the muscle enzyme histochemistry tests, which was a first in the country, under the guidance of Professor Sarla Das. She later extended this to muscle immunohistochemistry for muscular dystrophies, Western blots, mitochondrial respiratory chain assays, and genetics, and now tissue culture. It is indeed a journey spanning a wide arch from basics to cutting edge. And it is no doubt that she is the face of myopathology in the country. In electron microscopy, Dr. Gayathri's expertise, particularly diagnostic electron microscopy, has been a great boon to clinical service. I must particularly mention her contribution in the diagnosis of neuronal ceroid lipofuscinosis, and for decades, the diagnosis was often based on skin biopsy, particularly by you. She was also instrumental in setting up a state-of-the-art neuromuscular lab in our Neurobiology Research Center. Apart from her invaluable clinical service, she has played a huge role in capacity building in the country. She shared her expertise with pathologists and technical staff from across the country, from Chennai, Vellore, Trivandrum, Delhi, Hyderabad, Chandigarh, to name just a few of them. Dr. Gayatri is a very enthusiastic teacher, ever willing to share every bit of knowledge. She has mentored several students and has been a guide for many PhD scholars, neuropathology students, and a co-guide for more than a few DM neurology theses. Her scientific inputs have supported many external PhD students as well. Dr. Gayatri's research has focused on limb-girdle muscular dystrophy, congenital myopathies, mitochondrial disorders, and neurometabolic disorders, to mention just a few. She has had several research projects as principal investigator and has over 250 publications in peer-reviewed journals. She has several awards and recognitions. She is a member of the National Academy of Science and a member of the Expert Task Force Group for Neuromuscular Disorders of the Indian Council of Medical Research. Apart from all these abundant academic accomplishments, Dr. Gayathri is a wonderful and warm human being. Dr. Gayathri is held in high esteem by all her colleagues for her hard work, intellect, and integrity. She is very affectionate and caring. We will miss her bright and cheerful presence, and of course, that lovely, brilliant smile that you're seeing on the screen. I will miss her as a colleague and a very dear friend. She is ably supported in all her endeavors by her loving husband, Mr. Vijay Kumar, and her daughter, Dr. Kadambari, and son-in-law, Dr. Kevin. As February end draws near and new directions open before her, we wish her and her family great happiness, health, and success in all that she chooses to do. On behalf of the department, thank you, Dr. Gayatri, for your invaluable contribution. However, this is not goodbye. We wish to see you continue to provide your inputs in our teaching sessions and in several other activities. Thank you.
Thank you.
Thank you, Madam. Madam Professor Gayatri has been an epitome of simplicity, devotion, respect, dedication, enthusiasm, and thus is a role model for many students, which includes me. We now have the felicitation of Dr. Gayatri by our beloved director, Dr. Satish Girimachi, and the registrar, Dr. Shekhar Sheshatri.
You can say it. You keep sitting.
Look to hold it on both sides. Yeah.
Oh my God.
Thank our in-charge director and in-charge registrar for this felicitation. I now request our in-charge director, Dr. Satish Girimachi, to address that audience.
Good afternoon, and it's my pleasure to invite you all, welcome you all for this symposium on myology. And I would say that it is in the fitness of things that this is being organized to felicitate Professor Gayatri who has put, I would say, her heart and soul in this area and has made immense contributions to the field of myology. In fact, I know this for a fact because she lived for a long time and we were good neighbors, good friends. And I had seen her coming very late in the evenings from her lab, 7 o'clock, 8 o'clock, 9 o'clock. So you can see the amount of dedication and hard work and conscientiousness. And also, I think that kind of, let's say, a fire in the belly that she had for the area. And that kind of, let's say, passion that she had for this area. And then, of course, given all this and then her academic brilliance, one can see the accomplishments that she has had, as it was read out by the HOD. And I have always associated her with electron microscopy, congenital muscular dystrophies, mitochondrial disorders, the rare ones where her inputs really go a long way in terms of deciphering what the diagnosis is. And I thank the Department of Neuropathology for having put all the effort to put together this academic feast. And I'm glad that we will have a chance to listen to world leaders in this area, both within and outside India. And it's also heartening to see that many of our senior distinguished alumni, big stalwarts, are going to take part in this symposium. A special welcome to all of them. And I am sure that this symposium will be highly educative, enlightening, and it will be some kind of a landmark kind of a symposium. And before signing off, I convey my best wishes to Dr. Gayatri and her family, Mr. Vijay Kumar, who is here, Kadambari, her daughter, and Kevin, Sanitla, in the journey that they have after this. So all the best.
Thank you. Thank you.
Thank you, sir. Thank you for those warm words. We are now starting with the scientific program.
Wonderful.
Okay. I request our chat register to say a few words.
Thank you very much, and all the best, Gayatri. We remember the growth of the Department of Neuropathology because some of us are people who came here in the late 70s, like Tali Saab here and Dr. Shankar and all were people who are basically the foundation of this institute. But we are all people who are here from the late 70s and the early 80s, and we've seen the department grow from what it was then to the kind of stature that it has now, not just in the country, but all over the world. We are also aware that the electron microscope itself has gone through a couple of generations. And I think the oldest one has pride of place in the museum that Dr. Shankar has so lovingly set up, and the rest of you are managing with equal love and dedication. I would like to actually echo the point that the in-charge director, Dr. Satish Giramaji, made, that the academic feast today is absolutely remarkable. And as much as it is sad to say bye to you, it is also heartening that we are doing so, recognizing and celebrating what you stood for in terms of scholarship and the contribution to this particular aspect of neuropathology, which is myology, and the study of a condition that we are all familiar with because it starts in early childhood, which is Dushan's. So all the best, Gayatri, all the best, Vijay, and stay healthy. And please be in touch, and
Yes.
let's enjoy a really, really academic feast going forward.
Thank you.
Thank you, sir. That was nice. Before we start with the scientific program, we have this great honor of inviting and introducing the chairpersons for today's symposium. And these chairpersons have been the teachers and mentors for not only Gayatri, but also the teachers of teachers and mentors of us. I would like to start by introducing Professor Sarala Das, who was the former professor and head Department of Neuropathology in MATS, was the former dean in MATS, and also she has been the president for various societies, organization bodies, including Neurological Society of India, Neuropathology Society of India, and member of editorial board Neurology India. She was instrumental in establishing the diagnostic and research facility, including enzyme histochemistry and electron microscopy, for muscular disorders for the first time in India in MATS. She started the PhD program in neuropathology. She has received many awards and honors, including Lifetime Achievement Award, and for the outstanding contribution and exemplary achievement recognition. And she has delivered many guest lectures and orations, and she has around 100 publications in national and international journals, chapters in books, and recent advances. We are very fortunate to have with us Dr. M. Gauri. Madam is presently the Emeritus Professor of Neurology at the Institute of Human Behavior and Allied Sciences, New Delhi. She is also the Chairman, Department of Neurophysiology and Senior Consultant Neurologist at Sir Gangaram Hospital and the Gangaram Institute of Postgraduate Medical Education and Research, New Delhi. She is also the Honorary Advisor for Neurological Research, ICMR, and former Director, Vice Chancellor, and Senior Professor of Neurology in MATS. She has received many achievements, and she has been the member of the National Institute of Health International Brain Disorders Program USA. She has been an expert member, WHO Neuroscience and Committee for Revision of ICD-10. She has received many honors and awards, which includes Vasanti Devi Amir Chand Prize and Om Prakash Basin Award and Kugelberg Award conferred by the International Federation of Clinical Neurophysiology, Washington, DC. Her main research interests include neuromuscular disorders, motor neuron disease, monomelic amyotrophy, neurotuberculosis, neuroepidemiology, Japanese encephalitis, and she has around 200 publications in various journals and chapters in books, and has given 40 orations. I am at most delighted to introduce now our teacher, Dr. S.K. Shankar, who was the former director, MATS, retired emeritus professor, Department of Neuropathology, MATS, former principal coordinator, Human Brain Tissue Repository at the Neuropathology Research Center in MATS. He was instrumental in establishing the CJD registry in India, which is a national referral center for the diagnosis of CJD on brain biopsies. He was also the temporary consultant to WHO for transmissible spongiform encephalopathies. He was the brain behind the establishment of the Human Brain Tissue Repository for Neurological Studies, a national research facility which promotes the concept of brain donation. He has received many fellowships and is a life member of many prestigious organizations, societies, and bodies. And he has delivered around more than 18 orations and around 430 publications and also more than 50 book chapters. I am glad to introduce now the next chairperson, that is Dr. Sundaram. Sundaram, who is presently the advisor for DMP pathology, Vasatarakam Indo-American Cancer Hospital and Research Institute at Hyderabad. She was the former dean, senior professor, and head of pathology in Nizam's Institute of Medical Sciences, Hyderabad. She was pivotal in establishing the first neuromuscular laboratory at Nizam's Institute of Medical Sciences. She collaborated with many prestigious research institutes, which include CCMB, CDFT, and also demands for genetic studies in mitochondrial myopathies and muscular dystrophies. She has delivered many orations and received the Best Teacher Award, and she is also the present president of the Neuropathology Society of India. Her major areas of interest in myology include mitochondrial myopathies, inflammatory myopathies. She has published more than 250 papers in national and international journals and a book on muscle disorders, muscle biopsy and muscle disorders. Now, I am very delighted to introduce Dr. Arun B. Tally, who is presently the Emeritus Medical Scientist and also Honorary Professor of Neurology, Bangalore Medical College. He was the former Senior Professor and Head of Neurology, National Institute of Mental Health and Neurosciences, Bangalore. He has facilitated the establishment of neuromuscular laboratory at NIMHANS, and he has involved in many research, which includes the field of neuropathology, peripheral neuropathy, myasthenia gravis, and mitochondrial disease. He is the member of many academic bodies and societies. He has conducted several CME and workshops. He has delivered many invited guest lectures and in various institutes and universities across India and abroad. He has supervised several dissertations and has been a very good clinician and teacher. And his major area of interest in biology include mitochondrial disease. He has published over 100 publications in various prestigious journals. Now we move on to the main lecture series of the symposium. Before we start with the lectures, we have a short video clip of the messages for our madam by these dignitaries whom I just now introduced. I request to play the video now.
Dear friends, it is a moment of immense satisfaction and honor to be part of this academic meet organized by the Department of Neuropathology in NIMHANS at the felicitation of Dr. Gayatri on her superannuation. Gayatri joined the department at NIMHANS in 1983 as a research scholar a year after me. Even as a novice, she showed keen interest and provided me the able hands I needed to pursue my studies in muscle diseases. A hard-working, honest, and dependable researcher, she shouldered the difficult task of establishing the muscle lab. The results were often too good to be true. I remember a national conference where the histochemistry pictures in her presentation were alluded to textbook, and Dr. Dastur rose to support our claim of authenticity. Dr. Gayatri obtained PhD from the NIMHANS in 1995 and has claimed the ladder to be a professor in 2012. To her credit, she has been a PhD guide and co-guide for several candidates and a principal investigator in prestigious projects. The transition of Gayatri from a pure science postgraduate to a diagnostic muscle pathologist has been a labor of love and ardor. Besides the departmental family, Gayatri has been supported at home by her husband, Mr. Vijay, and their daughter all along. On this momentous occasion, I wish her the best for her ongoing projects and continued association with NIMHANS. Thank you.
I'm happy to say this about the following, about Gayatri, who has been with us for a long time in the Department of Neuropathology. Professor Gayatri has worked as a cytogeneticist at the Institute of Medical Oncology, and from there she decided to shift to NIMHANS. She worked as a myologist at NIMHANS for more than 3 decades. and she joined as a research fellow and superannuating as a professor of neuropathology. She worked with Professor Ladas, professor in the Department of Neuropathology, and is initiated into the field of myology and electron microscopy. Professor Gayathri is more proficient in human myology and established a division of myology at the National Brain Research Center with her colleagues. She spent most of the time in human myology, a disease of the skeletal system, and with international collaboration. She trained technicians in histochemistry, muscular diseases, and electron microscopy. Professor Gayathri is a good teacher and taught pathology, and residents posted here for training for more than 3 decades. Electron microscopy is a technique she used to understand the disease process. She worked with Professor Y. Rammohan, who started the electron microscopy lab and assisted the faculty in carrying out electron microscopy of tumors and other tissues. Professor Gayathri is a good teacher in myology and has been assisting the Department of Neuropathology in diagnosis. There is no doubt to say that we will miss Gayathri and her experience in myology and electron microscopy. After superannuation, she will consider continuing their studies in myology and train the students as a part of second innings. I wish her all the best in her post-superannuation time and hope she will extend her expertise in teaching the students and residents and widening the field of human myology at NIMHANS.
This is a token of my appreciation of Gayatri for her excellent contributions to the field of neuromuscular and neurometabolic disorders. Having known her since she entered the portals of NIMHANS 4 decades ago, I am amazed at the unrivaled experience over the years in investigating neuromuscular disorders. I was associated with the research, a comparative morphological study of skeletal muscle in infantile neuromuscular disorders and human fetuses, which led to the award of PhD degree to her. There was no looking back, and Gayatri tenaciously pursued research in the field. She epitomizes sincerity, discipline, and integrity, and her publications are indeed a reflection of her methodical and meticulous attention to detail. Her close interaction and collaboration with clinical neurologists has indeed paid rich dividends in documentation of patients with a range of muscle and mitochondrial disorders. It is indeed very creditable that she was instrumental in establishing an international center for genomic research and neuromuscular diseases. I continue to interact with her in the expert committee on neuromuscular disorders of the Indian Council of Medical Research, and I'm impressed by her astute and exemplary comments. An important milestone is the creation of Human Skeletal Muscle Disease Biobank, which will provide a rich repository of tissue for in-depth research. Above all these academic issues, she is indeed a warm person with a pleasant and cheerful disposition. Gayatri, it is difficult for me to come to terms that you are retiring from NIMHANS, but I am certain that you will continue to pursue research and share your experience and expertise with colleagues and students. My best wishes to you.
It's my pleasure and privilege to chair the Myology Symposium organized in honor of Dr. Gayatri. I appreciate the nice gesture of Department of Neuropathology NIMHANS for celebrating the successful career of Dr. Gayatri and making me a part of it. I have a long association of more than 3 decades with Dr. Gayatri. I greatly admire her diligence in the standardization of techniques in muscle and EM lab. She developed the state-of-art neuromuscular laboratory in NIMHANS. Her dedication and hard work in the field of myology and EM brought her a lot of laurels. Her passion and contributions in mitochondrial diseases are particularly commendable. She helped me solve many a difficult case and always was very helpful. She is a dear friend and a very loving and caring person. I wish her success in her future endeavors and may God bless her with health and happiness. Thank you.
I thank all the dignitaries for all those wonderful messages. Now we will go to the main lecture series of the symposium. There is a small change because of some technical issues. We'll have the second lecture. Yes, we'll be starting with the second lecture by Dr. J. Anthony. We'll be speaking on how should we teach myology nowadays. And for this session, we have with us Dr. M. Gauri Devi. We'll be chairing this session, and I now request Dr. M. Gauri Devi to introduce the speaker and welcome.
It's a great pleasure and honor for me to introduce our good friend, Dr. Andoni Uritzbera, whom we have known for many years. He is the head of the Summer School of Myology. And I had the honor to have attended the program in the year 2002. And I must tell you, it's a very fruitful program for clinical neurologists, neuropathologists, and basic scientists. Andoni, you have done a very great job in this summer schools of myology. He is affiliated to the Institute of Myology, Paris, and is the former head medical director of AFM, or the French Muscular Dystrophy. He is the scientific director of the European Neuromuscular Center of Netherlands, and he is the deputy coordinator of French Neuromuscular Network, Marseille. He has been regularly visiting various countries as professor and a consultant for many pharma involved in the field. His main objective is to raise more awareness about rare diseases in emerging countries, and specifically in the context of novel cutting-edge therapies. He co-founded an NGO dedicated to humanitarian relief in the field of rare diseases. Of course, his major areas of interest have been muscular dystrophies and spinal muscular atrophy. We look forward to your lecture, Professor Andoni Uritzbera.
Okay, yeah, that's fine. Okay, good morning, everyone. It's a pleasure being with you to celebrate Gayathri's jubilee or retirement. I don't know how you call it. So we're going to talk about myology again, and the topic I've been given is titled, How Should We Teach Myology These Days? As you will see, this is a fast-moving field of science and medicine, and this is very exciting. So you should see, yes. This are just my disclosures. As I said, I'm mainly a clinical myologist. In other words, I'm dealing with clinical expertise, but I'm also a faculty teaching various institutions or schools, and we will talk about it today. But I'm also a freelance consultant nowadays for pharma. So what are we going to cover today? Of course, teaching myology, we need to know what, why, whom are we going to teach, how we're going to do that, and eventually where should we get trained in this very promising field. First of all, I'd like to pinpoint the importance of semantics. As we all know, myology is just an emerging discipline or science. It is at the intersection of neurology, pediatrics, genetics, pathology, and many other medical specialties. But actually, it's quite ancient, but it remained confined for many years, or actually many centuries, to anatomy and anatomists. But we observed with great pleasure a kind of a rebirth since the late 90s with all these developments in human genetics and so on and so forth. And currently, it's a very fastly expanding and very exciting field, which attracts many more people, and that's very encouraging. So we have new discoveries, and more importantly, we have numerous therapeutic advances. I mean, we are now capable of perhaps not curing people, but at least to treat them properly with a good clinical outcome. But actually, myology is a bit difficult to understand because it's somewhat a poorly delineated field with various overlaps with different and other specialties, and even semantics are confusing. I mean, there's a lot of debate about where the boundaries are. I mean, are we talking about myology or neuromyology exclusively? Are we talking about neuromuscular science, neuromuscular disorders, basic muscle science? All this might be confusing, especially for young students, you know, when they want to embark on a curriculum on muscle diseases. And I think we have two, not opposite, but distinct views of what myology is. It could be a very inclusive vision, including, you know, all these classic neuromuscular disorders that you're aware of, but also related disorders as ataxias, cardiomyopathies, spastic paraplegia, mitochondrial disorders, and so forth. If you're more exclusive, then you would just consider neuromuscular disorders as disorders of the motor unit, that's it, and exclusively that. And you will deal with lower motor neuron, the junction, and the muscle, and you will be interested by fundamental myology as well. So this is the current restrictive view or inclusive view of myology that we're using on a daily basis, considering that all disorders related to the motor unit will or may give rise to a specific disorder, and that's myology that we should teach. So of course, when it comes to the clinical vision, it becomes more and more complicated. I just listed here a few of the 400 and probably more disorders related to neuromuscular science. And we have to deal with anterior horn cell disease, nerve disease, neuromuscular junction disease, and finally with muscle fibers. And we have to teach all this to students, and that's a big challenge, as you all know. But again, when it comes to consider muscle science, I mean, we shouldn't be too narrow-minded. In other words, we need to also consider the central nervous system, and we have more and more examples where actually within a given neuromuscular disorders, you may have also brain involvement whatsoever. And that's the case, for instance, for Duchenne muscular dystrophy now, where we're quite interested in knowing why so many kids with Duchenne are cognitively impaired. So I think we have to open our eyes in a sense and being less inclusive than we have been in the past. Just to remind you that all this led to an avalanche of knowledge for the past 20 or 30 years with so many novel genes reported in literature, novel entities. All this has been published and is published regularly, and this is very fascinating. But again, you may be inclusive and restrict your knowledge to the purely neuromuscular disorders, or being more inclusive, such as this gene table published in neuromuscular disorders, aggregating all the related diseases I mentioned. And this is where we stand now, and we have to teach that. I mean, we have to teach the students now that we are not living in the same era. We are now capable of diagnosing patients properly with the genetic defect, and we are now capable as well to treat them. I mean, to provide them with gene therapy, pharmacology, and cell therapies probably in the near future. But so again, this will impact the way we teach myology. Another quite interesting point that we learned over the last 30 years, that there is a significant overlap between genotypes and phenotypes. I mean, we as clinicians, before, we were quite sort of living in a simple world where everything was quite delineated between limb-girdle muscular dystrophies, congenital muscular dystrophies, distal myopathies. Okay, yes, that's true, but it did help a lot to learn our students. But nowadays they have to understand that there's, for instance, the same gene capable of giving rise to different clinical entities, and just vice versa. So again, this is becoming very complex, and the students have to have a critical view of this, in the sense that it is not always black and white. That's the message for them. Another message we have to convey to them is that there is a change of paradigm in the diagnostic approach of inherited neuromuscular disorders. I mean, formerly we based our assessment mostly on clinical evaluation, and then came EMG, CK, and muscle biopsy was a quite important step. While muscle imaging was just at the beginning, and the genetic testing was extremely difficult because there were very few laboratories in the world. But nowadays, as we all know, clinical evaluation hopefully remains on the top one. I mean, it's essential, and we need to teach our medical students about how to examine patients, how to take history, and grab clinical clues as well. And as you can see here, the genetic testing now is almost in top 3, I mean, which is a reality, and we are performing less and less muscle biopsy, even though we do need experts such as Gayatri and others, and I'll come back to it later on. So as I said, the knowledge in myology has exploded in the last 3 decades, and even from the therapeutic perspective. And I just took this example of Duchenne muscular dystrophy, where from early days when we had this very nice clinical descriptions by Duchenne and others, then came the dystrophic the discovery of the dystrophin gene in 1987, and nowadays we have at least 3 or 4 different drugs capable of treating, not curing, but treating patients with this disease. So again, this is fascinating, and this is just detail of what's happening just in the field of exon skipping in Duchenne, where we now have at least 4 drugs being approved by FDA or being pending for approval. Same in Duchenne muscular dystrophy, where we are now also having another option for therapeutic, such as microdystrophin. As you all know, microdystrophin or mini dystrophin is a shortened version of this huge gene, and we are now capable of putting back into a muscle cell via a viral vector. In SMA as well, it has changed, I mean, quite a lot, and we have to teach our students that yes, you're capable now to prevent a type 1 SMA patient like this one. You may prevent symptoms to occur if you give this gene therapy early on time. So again, this is a totally different world and different atmosphere, and this is just the state of the art now for SMA therapeutics, where we have many different labs interested in providing or designing different drugs, such as gene therapy or oligoantisense nucleotides. Another point is important to consider. It's true, we focused mainly for the last 20 years on genetic diseases, on neuromuscular genetic diseases, but it's not all. I mean, the immune-mediated diseases is also important to know and to teach, because they represent an important number of patients, as we all know. So again, the advances achieved in immune-mediated myopathies have been tremendous. since the 70s, where the very first antibodies have been described. And nowadays we've got a panel of battery of very important antibodies, and we are now able to really customize treatments for each subgroup of myositis, for instance. And this has been demonstrated very nicely by various groups across the world, where now you can target specifically subgroups of myositis. So overall, I think the message we have to bring to our students, that there's a growing number of neuromuscular disorder which are not yet curable, but at least they are amenable to various therapeutic options. And I've just listed some of them, but the list is expanding almost every week or every month. So we need, well, I just addressed in this first part what we need to teach our students. Now, the question is, why should we teach myology? Of course, this is meant to translate scientific advances into clinical practice, and the ultimate goal is obviously to improve our patients' fate. Okay, we want them to get better, and if possible, cured, but it's almost impossible, but at least treated and having a good quality of life. I think another objective of teaching is to create more awareness, because all these diseases are rare. They're still difficult to pick up and to detect in the general population. So we need this awareness, and we need to attract more healthcare professionals and scientists in our field, because the more we are, the better. And this may lead in a very distant future, I'm afraid, but to a new autonomous medical specialty, where at the moment we're just a kind of a cult of very motivated, dedicated specialists, but we're not many enough, in a sense. Of course, we need to teach the students, which are the young generation, but we also need to teach and to refresh and update the skills of professionals already in place. And that's because even for us, I mean, things are going so fast. There are new clinical entities every day, novel genes, novel therapies. There are new techniques, exome sequencing or NGS, muscle imaging. All this has to be taught on a regular basis for everyone. So whom should we teach? And the point is that we need to teach a lot of people. We obviously think of healthcare professionals in the first place, but that's not the only ones. Of course, we need to teach medical doctors, all sorts of them in different specialties, but we need also to train paramedics, I mean, physiotherapists, which are now playing a greater role in clinical evaluation and clinical trials and so on. We obviously need to have a bunch of scientists being trained in myology and muscle science in general. That's not easy, but we need them on board. And this is a growing concern nowadays. The patients and advocacy groups are now getting trained, or they want to be trained, or they even organize their own training themselves. So how are we going to do that? The principles of teaching myology, in my view, but that's very personal, has to be translational. I mean, we need to go from the bench to bedside. I mean, from science to clinical application. It's always cross-fertilization between basic and clinical science. We should try to cover and address all neuromuscular disorders, including adult disorders, if you were a child neurologist, and vice versa. I think we have to be comprehensive. And it has to be customized according to the local and regional national context, for sure, and adjusted to the applicant's strenuous profiling trajectory. So these are the principles. And there are many ways to achieve that, as you all know. There are curriculum, sometimes full curriculum for graduates or postgraduates. You can rotate in clinical departments or in lab. That's very satisfactory. You can organize hands-on training, bedside teaching. you can organize or deliver a short duration workshops or courses, scientific meetings, and never forget that the material people are reading just as a paper or online are also important sources of information and therefore of education. And e-learning, as we all know nowadays, is taking a great place in our format, in our scheme of education. You can do that almost everywhere. In my view, again, I think the national level is probably the most relevant one because people speak the same language, they know each other more or less, and they have easy access to such training. At the international level, you know as well that you can get trained in many places. I mentioned here in Europe, the Paris School, but there are many other meetings, as we will see in a minute. We'll talk about the Translational Summer School and others. Okay, so for me, it's not an issue nowadays to get trained. As long as you're really motivated, you will find a place to get that. So this is just kind of benchmarking where I've just listed the various training courses available in Neuropathology these days. I must say that many of them have been either cancelled or adjourned due to the pandemic, but still they will probably be back again in the near future. So this is just the London course, which is very popular, which is a 3-day course. And obviously the OMC, the Asian Oceanology Center, which has been founded 19 years ago, 20 years ago by Ikuya Nonaka in Japan. And they have a teaching activity, and a pretty good one, either prior to the meeting or during the meeting, that they organize yearly in various places. I've just listed here, but they also organized it in India several times, as we know, thanks to Ikuya Nonaka and to Nishino, which is now the head. The World Muscle Society is doing a good job in teaching as well. And remember what happened last year, in last September, when the annual meeting turned virtual. Instead of having just 600 delegates, when it was in person, that just reached the quite exciting number of 3,000 people, 3,000 registrant for this meeting. And again, they had a teaching course which has been followed by almost 1,800 people, which is again was very successful. And even this year, in 2021, the Congress will remain virtual for obvious reasons. And I'm pretty sure that they will be successful. And I encourage all people. Last year for the WMS1, we had, I think, some 50 people from India, but I'm pretty sure that you could be more. And it's free. That's the big advantage. It's free nowadays. Okay, so more recently, the master classes of Treat and MD have been implemented 2 years ago. They're covering 2 or 3 different subjects, and it's free again, so you can attend with no fee, and it's usually very interesting. Just a few words about our own teaching activity, which is the Summer School of Myology that we organize in Paris, France. We've done that for 22 or 23 years together with Michel Fardeau. We trained a significant number of students, almost 800, from 70 different nationalities. And I must say that they were a good group of, a significant group of Indian students have been always there. Again, well, but I will skip that for the sake. This is the pioneers we had in 1998, sorry, and many of them are still now active in the field. Teresina Evangelista and in Paris, but many others are listed here. It's always good to see the old slides. This is the Institut de Myologie where we had this course, and what was sort of our mark is the fact that was interactive and still interactive with various workshops, hands-on workshops, either to review slides or to join a workshop on physiology and muscle physiology in particular. So it was a mix of lectures and again, interactive workshops, which has always been very successful. So we trained, as I said, many people, and this was my mentor, Professor Fardo, and the whole team was there, and with all the students. Okay, and in 2005, actually, again, we had people coming from all over the world, including 4 people from India. Okay, and one of them was here, as you recognize probably, Gayathri. And Gayatri received a diploma by myself and Professor Fardo and Professor Romero here. And she was so happy to get her diploma, and she was so proud. And she was close to Monique Jain, and Shefali Gulati was there as well from India. It was great here, I remember. Okay, so I'll skip that as well. Just to tell you that what matters most actually is the fact, after training, actually, there are many things you can do with the trainees and the students in general. Remote coaching is essential. Telemedicine, working on patients on even distantly is always important, and we've done that with many countries. We also acted as a go-between between local teams and European laboratories when it was difficult to get genetic studies done. Nowadays, it's almost the opposite. I mean, since genetic studies are so easy to get in India and so cheap, that we're tempted now to send our samples back to you. Anyway, so nowadays, and that's the slide for Paris, I mean, it's true that there's still a growing demand for this type of teaching, because people are fond of myology first, they're fond of Paris, they're fond of having social activities, but at present time we have to stop it. We will probably do something else next year. We'll probably turn virtual this year, but we'll be mostly back next year as in-person teaching activity. Okay, I think I will skip that for the sake of time, but it was just a slide telling you that we need also scientists, and we've done that together with Berlin University in Germany. And all these people on this picture were mostly basic scientists interested in muscle myogenesis, muscle development, and so on and so forth. So we need them as well. And to finish, I'd like to tell you that we expanded the teaching activities across the world because the Paris summer school was so crowded, in the sense that we had to export our module, and we've done that in various countries, as you will see. We started with Latin America. That was almost 10 years ago. It's still in Spanish, and it's very successful with 150, 200 attendees yearly. It turned virtual this year, last December, and we had a very important number of people, over 500 attendees, which is quite good. So again, I love these pictures because it was a time when we could just meet and touch each other. It was a great time. Nowadays, it's a bit frustrating, I must say. So, and you probably recognize some very famous pathologists, such as Dr. Analia Taratuto, that Gayatri knows, and probably Dr. Das and others. Okay, so we've done that in Brazil, we've done that in various places. We've done that as well in Russia. And again, I will go this very rapidly. At a time when myology was really quiescent, I would say. We really started from scratch. There was no muscle pathology at all. And nowadays, and Hans Goebel will tell you that later on, they have now successful myopathologists, and they're doing a great job. So that's very encouraging. So teaching is actually very useful in the long term. Never forget that. An interesting point here is that during the teaching activities, you should be interactive. And what is very popular in Russia, for instance, is to have clinical sessions in the presence of patients. Okay, we have questions and answers, and we examine people together, and that's again fascinating. And this is Björn Ud, that some of you know, which is the specialist of distal myopathy. I'm just showing now a couple of slides of the group picture performed in Russia for the summer school of Russia. And I'm showing that just because they are very artistic. I mean, Russians are very good at taking pictures, and group pictures in particular. Look at that. That one was also great. And we had Hans was there, Hans Goebel, and many other faculties from Finland, Germany, Werner Stenzel was there, I think. Look at that one as well. It was great. So I enjoy this nice pictures. They're very good at it. Anyway, and this, I think, the latest one in Moscow. So unfortunately, last year we had to switch to virtual. So again, it's a bit frustrating. Okay, so I will skip the MENA region, that is the Muslim or Persian world, where we did have some activities. In Lebanon, for instance, we had a school of myology. We had one in Kerman, Iran, many years ago, in this lovely city of Kerman in 2016, where very nice people, including, probably you remember, Yalda Nilipur, which is one of the best myopathologists in the world, and she is in Tehran. We've done that in Bahrain, in the Gulf area, and we done almost 2 years ago, in Dubai, together with my friend André Megarbani. This final slide about Africa, I mean, we should keep in mind that myology also has something to do with developing countries. I don't know how we should call them, but still. So we're also active on this field. We have to do it in French, and this is for the French part of West Africa. But again, this is a growing demand of neurologists and child pediatrician neurologists. So my two last slides, and I think I will just, yes, that one, the take-home messages. How should we teach myology nowadays? That was the initial question. The thing is that nowadays we're facing a growing demand of training from multiple target audiences. In other words, we have to also teach not only physicians, but other people. I talked to you about families, patients, farmer staff needs to know about this discipline. You have to be comprehensive, I told you already. And obviously, especially in myology, it's very global. I mean, all these rare diseases are scattered across the globe, and we need to interact between various groups. And hopefully that has been done for many years, and that's very encouraging. I do believe and predict that in the future, we'll have a mix of in-person and virtual formats, because I think people have been now used to all these webinars and interactive e-learning, and we won't be back to the initial format for sure. And I do also believe in individualization. In other words, what is really the added value for a teaching activity is when you coach individuals, okay, and individuals in particular. You need to guide them in their career, and it's kind of a mentoring, as we say. Another point is the abundance of information sometimes kills information. In other words, we're now seeing an avalanche of webinars of all sorts given everywhere. It's free. But still, the student might be lost among all this, and he really needs guidance for that. And the final thing is about the need of a specific teaching for muscle and nerve pathology, and I think Gayatri and others will be happy with that, in the sense that we still need, and I would say we probably need more and more muscle experts in terms of pathology. That's to validate variants or just to recognize new entities, it's absolutely needed. And we need to work on that, perhaps having a specific teaching course just for muscle pathology. And another trend is the fact that the industry is playing a growing role now in education. I know, is it a good thing? Is it a bad thing? I don't know. But we need support from industry, but they should let us totally independent about what we need to teach and whom we should teach. And that's apparently the case to date. And finally, it's good to teach. We've seen that. It's probably useful, but it's very difficult to assess what the trainees have been learning, and you all know that as teachers, but it's also difficult to evaluate the trainers, and this is the real challenge. So, okay, so again, Dhanyavad for your attention, and all my best wishes to Gayatri for Jubilee or for retirement, and I'm pretty sure we'll keep on interacting with you, Gayatri, in the very near future. Keep safe.
Thank you.
Thank you, Professor Andoni, for really enthusing everybody to learn about myology, to think about the muscle pathology. I know there is a great shortage of muscle pathologists in this country as anywhere else. And you have really explained to us how there's been a paradigm shift from what we used to do, like muscle biopsy. Now we move to genetics, and how it's so important to spread the message, not just to the doctors or professionals, even the patients and their caregivers. Thank you very much. Very enlightening lecture. Thank you.
You're welcome. Thank you.
Thank you, sir, for this wonderful lecture. Thank you, madam, for chairing this session. We are very fortunate to have with us Dr. H. Gobel, and he'll be speaking on reflections on congenital myopathies, and Dr. Sarala Das will be the chairperson for this lecture. I have the glad duty of introducing Dr. Hans H. Gobel, who is presently the consultant at the Department of Neuropathology, Charlotte, Berlin, Germany. He was the former head of the Department of Neuropathology, Johannes Gutenberg University, Germany. He has received several awards, which includes the Moore Award by the American Association of Neuropathology, Saul Corey Lecture Award at the American Association of Neuropathology, Russian Prize by the German Myological Association, Alphonse Jacob Medal by the German Society of Neuropathology and Neuroanatomy. His major area of interest and expertise is in the myopathology of congenital myopathies. He has over 450 publications, both in the field of myopathology and other neuropathology aspects. Over to Dr. Hans H. Gobel.
Can you please activate the sharing of the screen for us, please? It's not activated yet. Oh, yeah. Very good, thank you.
Oh.
Can you see the screen now?
Yes. Okay.
Thank you.
Good morning, afternoon. I'm sorry that I mixed up yesterday's schedule with today's schedule, but I would like to pay my welcome to Professor Gayathri, to Dr. Nandish, and to the chairperson and everybody in the audience. Now, actually, the change from the temporal change of the talks between Professor Ortiz Perea and myself actually has some logic in it, because he talked about general aspects of myology, while I will go into some details. Now, I would like to talk to you about my interest and my reflections on the congenital myopathies. Well, the congenital myopathies, compared to several other groups of neuromuscular disorders, are a recent event, because they have come up with the introduction of modern myopathological techniques, that is the enzyme histochemistry and the electron microscopy. And Victor Dubowitz many years ago called them and wrote an article on it, the new myopathies. What happened to these diseases that actually existed before, nobody knows. And I have not found, and I am not aware of any article that produced anything that could now be called a congenital myopathy in that pre-enzyme histochemical and pre-electron microscopic era. Now this, we would divide the congenital myopathies in structural congenital myopathies, which actually are the hallmark and which are the definition of the congenital myopathies, and unstructured ones. Well, here we have the structural congenital myopathies, and there are three classical forms: the core myopathies, the nemaline myopathies, and the centronuclear myopathies, which actually have been described in the 50s and 60s. Congenital fiber type disproportion, from my point of view as a myopathologist, is not a disease, but it is certainly a disease for many clinicians. These are the classical ones. And then we have some rare forms, which the genes of which are known, and they are listed in the left column with cap myopathies down to cytoplasmic myopathies with the respective genes that are mutated. And there are still some that have very specific morphological or myopathological features, the genes of which, however, are still unknown, and these are the cylindrical spirals myopathy, the fingerprint body myopathy, and the crystalline body myopathy. Well, the classical forms, core and nemaline myopathies, have actually been described in the late 50s and early 60s. And up to date, it is not known what is the genetic background of these original patients, families, or publications. And that brings into something into which I have engaged as a hobby. It's eponymic and non-eponymic molecular historionosography. That means description of first published cases and their molecular background. And I will give you a few examples of these. Eponymic means they are related to a particular name, like Duchenne muscular dystrophy, Emery-Dreifuss muscular dystrophy, but there are hardly any in the group of congenital myopathies, more or less like a silent agreement among all the describers not to name any newly described congenital myopathies after the first author. So this is one of these. This is so-called spheroid body myopathy. And you see the spheroid bodies here and here and here in the muscle fibers. This is the electron microscopic arrangement where you see sharply demarcated bodies of granular and filamentous material as evidence of the spheroid bodies. Now, this comes from a huge American family with branches in Oregon and Indiana. And I happened to be in Indiana at that time and saw biopsies of these patients, which we published actually in the mid-70s. And this also had the feature of accumulation by immunohistochemistry of other proteins like desmin, alpha-B crystalline, and here you see the spheroid bodies, and here you see the upregulation or overexpression of these proteins. Now, and finally, Dr. Tfaroud from the Department of Genetics, very many years later, after the first publication, found the mutation in the spheroid body myopathy, a mutation in the biotin gene. So this is one example of this eponymic and non-eponymic molecular historionosography. This is another one from. This is familial myopathy with probable lysis of myofibrils in type 1 fibers. And that was published by the neuropathologist Pat Cancilla in Los Angeles in 1971. Now it is known as either hyaline body myopathy or myosynopathy. And these are the two children in the original publication who were affected. And the muscle biopsy actually showed very characteristic features. This is a modified trichrome, and you see this is the normal muscle fibers here. But here you see these very light, opaque areas which are devoid of sarcoplasm and sarcomeres. These are the pathological features. In an oxidative enzyme preparations, these do not give any reaction for these oxidative enzymes. This is the normal part, this is the pathology part. But when you go to the ADPase preparation, you see that these areas are still there and still there and still there, but they give a reaction. So they contain ADPase activity in these surrounding areas here, which later were called hyaline bodies. And this is the electron microscopic aspect of this. Among the myofibrils and beneath the sarcolemma, we see these granular material here, occasionally with some filaments, which apparently contain these ADPase activity. And finally, Nigel Lyne's group in Perth, Australia, found the mutation in the MYH7 gene in one of these original patients, the girl who died when she was in her 30s, and there was a post-mortem study of genome, and this this missense mutation in the MYH7 gene was found as the origin of the of this form of myosynopathy. And the last one is a form of congenital muscular dystrophy, actually by McCusick, called the muscular dystrophy of the Eichsfeld type, which was published in 1980. And this was then reinvestigated, and there were actually inclusions which reminded us of Mallory body, so that we call the Mallory body-like inclusions in hereditary congenital neuromuscular disease. And this is from this large pedigree here, and these are the 4 patients who actually were affected and of whom we had biopsied here with multiple intermarriages over the centuries. And this came from a very particular area in the center of Germany. This is here, and this is called, as it's read here, the Eichsfeld. And the peculiar thing is that this is a Catholic enclave under jurisdiction of the Archbishop of Mainz, whereas the surrounding people are also all Protestants. So this is an area of inbreeding and intermarriage among the Catholic inhabitants in this area, and that brought forth this peculiar condition. These are such Mallory body-like inclusions as you see them here, and you also see them here. And so these are also related to accumulations of other proteins, and in this case, desmin here and here and here and here, as we were able to show. And several years later, in this family and in others, there was a mutation identified in the selenoprotein or selenon gene, a homozygous del92 nucleotide mutation as the cause. So this then is another example of this eponymic and non-eponymic molecular historionosography. But the majority of the genetic diseases and their original descriptions so far have evaded this kind of study, and it would be very interesting to go into the archives where still either blocks are left to identify mutations in these original descriptions or in autosomal dominant conditions where descendants might still be known, to test these descendants in order to find the mutations in the original descriptions. So these are some of these examples these are the ones we studied here. And there were very many years between the years of the original publication, like this one, 1980 to 204, or 1971 to 206. So it takes about 30 or more than 30 years really to complete such retrospective or retroactive studies. And there are some of these congenital myopathies, the original publications of which have now been molecularly actually solved. A very special one is the one of the history of Nemaline myopathy, which actually goes back to 1958. And although it's Dr. Shai is credited with the first description in 1963 of this disease, actually it was Dr. Rai from Australia, from Rai's syndrome, who actually described these first in paraffin material, as all the other three original classical forms were also described in paraffin material. Now, I already pointed out to certain accumulation of proteins in these congenital myopathies, and these are then part of the newly established form of protein aggregate myopathies. Now, this was brought out by immunohistochemistry. So protein aggregate myopathies mean that there is protein, usually sarcomeric proteins, accumulating within the muscle, diseased muscle fibers. In certain muscular dystrophy, it's the opposite. The protein that is supposed to be there, and these are usually sarcolemmal proteins or nuclear proteins, are actually deficient. They are reduced or they're absent by immunohistochemistry. So actually, the introduction of immunohistochemistry brought very important certain features into myopathology, which actually often leads also to subsequent molecular studies. So, and that means from myopathology to molecular mutation, either via immunohistochemistry or immunoblood, and recently also through laser capture, microdissection, and mass spectroscopy, of which I will give you an example right away. So these protein aggregate myopathies, and I read this for you to make it clear and concise, are mainly genetic conditions except sporadic inclusion body myositis marked by aggregation of proteins within muscle fibers. The mutant proteins are majorly of sarcomeric origin. The mutations are mostly heterozygous and autosomal dominant. And I think we can stop here. So this protein aggregation in myopathology has certain aspects. It's in hereditary diseases or in non-hereditary diseases like sporadic inclusion body myositis. It is intracellular or it's maybe extracellular, and that is well beyond the muscle pathology. There is a disease entity versus a lesion, for instance, in cores or in ragged red fibers. There's also protein aggregation. Then there are filamentous versus granular or soluble inclusions. And the morphology of the protein aggregation is by light microscopy as inclusions, bodies, and soluble proteins, and electron microscopy as filament aggregates, granular aggregates, or inclusions, rods, tubular aggregates, and so on. Now, the protein aggregate myopathies are well beyond the congenital myopathy. So the myofibrillar myopathies are the core group of conditions, but also in distal myopathies, in hereditary inclusion body myopathy, and even in toxic myopathies due to emetine, for instance, there might be accumulation of proteins due to conformational changes of the proteins, and in some there are just lesions of this. Here, this is an example. Here we see in a modified trichrome preparation these peculiar material which here accumulated, and that is rich in desmin and very many other proteins. Here at the electron microscopy level, we can actually mark by gold grains, by gold grains we can mark the filaments in here. And this is another protein that is usually a sarcolemmal protein, dystrophin, as you see, but it also accumulates at this displaced location here inside the muscle fiber. And again, we can actually further corroborate this with immunoelectron microscopy. These disorders do not only affect the skeletal muscle, but also the heart, particularly the ones where we have mutations in the desmin gene, but also in the alpha-p-crystalline gene. And these are the proteins found in relation with myofibrillar myopathies, which actually are a certain form of congenital myopathies, a subgroup. And we have proteins of cytoskeletal, transsarcolemmal, chaperone form, sarcomeric proteins, etc. So this protein aggregation is a very new concept of myopathology due to conformational changes in proteins, often mutant proteins, which cannot be degraded, usually outside of the autophagic compartment. And we see protein aggregation in congenital myopathies in core diseases, cap disease, reducing body myopathy, actin filament aggregate myopathies, and hyaline body myopathies. And for instance, aggregation of proteins in cores, these proteins have been identified in proteins. Here you see accumulation of the ryanodine receptor protein in a central core disease in these cores here as evidence of this protein aggregation. Another one is in caps. Here, these are caps at the electron microscopic level, and these are rich in quite a large number of diversified proteins here. This is actin-related myopathy, which is actually due to ACTA1 mutations, and this is a very severe, often rapidly fatal disease. And this boy died when he was 4 years old. And in his muscle biopsy, he had these areas immunohistochemically marked by an antibody against actin here, accumulating in these muscle fibers. And you see in the ADPase preparation here, since this is actin here, we see these defects here, and we see this here. That means this is the accumulation or overexpression of the protein actin in a granular or in a filamentous form, which is devoid of the ADPase, just the opposite what I have shown you in the hyaline body myopathy. And this is what we see here, the filaments here. This is such an aggregate of filaments, and these are labeled with the respective gold grains by immunoelectron microscopy in antibodies against actin. So this is another example in myosin storage myopathy, but here a lot of studies have been done, but only myosin heavy chain were found. Whereas in very many of these these protein aggregate myopathy, there is a vast number of different proteins. Here only these have been begun. And other proteins that have been tested were actually found negative. Sarcomeric one, sarcolemmal one, and others as well, indicating that these were pure protein aggregates. And so I think that there are two types of these protein aggregate myopathy. One, due to catabolism, that proteins cannot be catabolized because of conformational changes, and also anabolic ones, where there is a defect in development, and this is myosin storage myopathy, where is the where there is a defect in the formation of myosin or thick filaments, but rather remain at a granular stage in the development. And finally, another one is a laser microdissection mass spectroscopy. And this is from a seminal paper by Carsten Bennemann at the NIH and his group, where they isolated reducing body myopathy. In reducing body myopathies, reducing bodies here. They cut them out with the laser beam, and then submitted it to mass spectroscopy. Here, this is the respective reducing body, and they found the FHL1 protein as an overexpressed protein. From there, they went to the gene, FHL1 gene, and looked for mutations, and they found mutations. And since then, FHL1 as a gene on the X chromosome in this X-linked disease has been documented many times as mutant in reducing body myopathy, but also in other allelic forms where reducing bodies have not been produced. So recently, new congenital myopathies have been described, and I will just go into this very quickly. And I listed these from the World Muscle Society abstract book here. These are the new ones that have been described here at these WMS congresses. And I don't go into details here, but here are these three from the Congress of 2015. But when you read these, recessive loss of function due to these SNCA4A mutations, or this title, it's very difficult how to call these congenital myopathy. Not like rod myopathy, core myopathy, centronuclear myopathy, CAP disease also. And there are others. This is 216, where they described 6 new such congenital myopathies. And there is one, there are 2 in 2017 and 1 in 2018. And this is the last one here from 2019. So there again, there are 2 newly described, again, very complicated names. And the genes that involved in these newly described congenital myopathies actually have amounted to 22 up to the, and these are the ones which are not yet present in the gene table, where new genes also have been confirmed up to the recent issue. Now, and this actually may call for a new nomenclatorial classification of the congenital myopathies. And this is such a suggested form. Following the CDG, or congenital disorders of glycosylation classification, which means CDG1A, now preceded by the respective mutant gene, like here PMM2 CDG, we could actually also rename the particularly new congenital myopathy. These are old examples. NEM3, for instance, congenital myopathy with ACTA1, where we put the congenital myopathy, or CM, in front of the name, and then we add the respective gene. Core diseases is ryanodine receptor, this is trianidine, and this is contactin, and we could actually arrange all these congenital myopathies whose gene mutations are known in a new fashion, which would actually ease the communication and understanding within the myological community. So I thank you very much, and many happy returns to Dr. Gayatri for the very many years of hers to come. Thank you very much. Okay.
Thank you, sir, for an enlightening lecture. And I'm sure you have created great reflections in our mind about this topic. And I thank Madam Dr. Saladas for chairing this session. We move on to the third lecture for today by Dr. Nishino on autophagic vacuolar myopathy. And we have Dr. Shankar SK for this session to Dr. Shankar Escape to chair this session. And let me introduce Dr. Vishnu. He is presently the director at the Department of Neuromuscular Research, National Institute of Neuroscience, National Center of Neurology and Psychiatry. He is also the director of 2 departments in Medical Genome Center in the same institute, that is National Center of Neurology and Psychiatry. Currently, he is a guest visiting professor at 4 universities across which spreads across Taiwan, China, and Thailand. His major areas of interest and expertise is in myopathology, hereditary or genetic disorders, myositis, and he has more than 500 publications in PubMed listed PubMed journals. Over to Dr. Vishnu for his lecture on autophagic macular myopathy.
Thank you very much for your kind introduction, and I will share my slide. So I'm going to talk about autophagic macular myopathy. So first of all, I'm honored to be part of this special symposium to celebrate the official retirement of Professor Gayathri, who contributed the establishment of muscle pathology diagnostic system in NIMHANS. Okay, so let me start my talk. So this is the list of, well, diseases in which you see autophagy-related pathological findings. So I think the most important and probably the most famous, one is Pompe disease, which has long been known to be associated with the autophagic, peculiar autophagic vacuoles, which contain glycogens inside. And the other one includes the autophagic vacuoles with unique sarcolemmal features, which I will focus on this today. And the other one is those with rim vacuoles, for example, GNE myopathy. Actually, there are a number of patients identified in India, many of them from NIMHANS, and oculopharyngeal muscular dystrophy and oculopharyngeal distal myopathy, for which actually the causative gene have been identified just recently. And also inclusion body myositis and others. And I don't go into the detail today, but sometimes you see autophagy related, which targets the mitochondria, which is called mitophagy, and mitophagy can be seen in certain muscle diseases. And also sometimes nucleus is targeted by subject to autophagy, which we call nucleophagy. But I'd like to focus on this condition, the autophagic vacuoles with unique sarcolemmal features. There are 2 disorders. One is Danon disease, and the other one is X-linked myopathy with excessive autophagy. I'd like to start with Danon disease. Danon disease was originally reported as lysosomal glycogen storage disease with normal acid maltase. What does it mean? So the only lysosomal glycogen storage disease is Pompe disease, because in all other glycogen storage diseases, enzymes are located in the cytoplasm, which are associated with glycogen metabolism or breakdown in the cytoplasm. In contrast, the causative gene, the deficient enzyme in Pompe disease, which is acid alpha glucosidase, is actually a lysosomal enzyme, which degrades glycogen within the lysosome. So lysosomal glycogen disease means Pompe disease. But acid alpha glucosidase, or which is also called acid maltase, should be deficient, but it is normal. So it's the very tricky or paradoxical name. But so what it means is that pathologically, it looks like Pompe disease, because you can see vacuoles like this, and they claim that there is a glycogen accumulation within the vacuoles. But acid maltase or acid alpha glucosidase activity was normal. That's why they named this disease as lysosomal glycogen disease, lysosomal glycogen storage disease with normal acid maltase. Actually, this is now called Danon disease, And Danon disease is caused by mutations in LAMP2 mutations, and LAMP2 is deficient when you perform Western blotting or immunohistochemistry. LAMP2 gene is located on X chromosome, long arm of X chromosome, and so this is actually an X-linked disease. There are more than 100 mutations have been already reported, and the main clinical features include hypertrophic cardiomyopathy, although this later changed to dilated form in the long run, and myopathy and mental retardation. So some people call this the clinical triad. But now we know that many patients actually also develop retinopathy. So if you really carefully examine their retina, they often have some abnormalities in their eyes. The only therapy at this available, the curative therapy at this moment available, is cardiac transplantation. But the actually gene therapy is under development at the moment. Of course, this is an X-linked disease. So in most cases, probands are males, and typically patients develop, start to have symptoms in their teens, and they develop cardiac failure around 17, so several years after the onset. And interestingly, once they develop cardiac failure, they die within around 2 years on average after the development of cardiac failure. In female patients, the onset is later. They usually are found to have abnormality in the cardiac. They usually found by their cardiac symptoms, and they develop some symptoms in their 30s. But again, interestingly, once they started having cardiac failure, on average after 2 years they die. So regardless of the sex, once they develop cardiac failure, they will die in 2 years. So you have to plan cardiac transplantation early, even in female patients. But there are actually, as I mentioned, that the female patients usually develop the disease later, typically age 30s or even later. But there are exceptional cases. There are reports of early onset cases. In this case, 13-year-old girl. So actually the phenotype is almost as severe as typical male patients. And there is another report. They also report that the onset is they report 2 patients. One patient developed the disease at age 10, the other one age 13. So again, these patients have very similar condition as typical male patients. Okay, so this is muscle pathology. Although the original report mentioned that the muscle pathology is very similar to Pompe disease, but actually in my eyes, in most cases, the muscle pathology is very different. So the picture, H&A picture on your right is the muscle from Danon disease patient. The panel on the left is the control. They look very similar actually, but the only difference is there are tiny like basophilic granules within the cytoplasm. So actually they are autophagic vacuoles. So I have to tell you that if your muscle pathology, the quality of your sample, muscle pathology sample is poor, of course you will miss this type of, subtle changes. And the typical artifacts are big vacuoles, which are caused by improper handling the sample, such as the defrosting the samples, or improper fixation, and you have many ice. If you have many ice crystals, you'll get a lot of vacuoles inside. If you have such vacuoles, of course, you will not be able to identify those tiny vacuoles, tiny granular structures. So, but if you look at the electron microscopy, then you can notice this type of autophagic vacuoles. But so this is autophagic vacuoles because it contains a lot of autophagic materials like wall-like structures, electron-dense materials, but this is very unique because if you look at the vacuolar membrane, actually it has another layer. This layer is actually basal laminar. The electron density and the structure is exactly the same as basal laminar. But the basal lamina should be present in the sarcolemma. It means the muscle fiber membrane should not be present in the vacuolar membrane. In the intracytoplasmic vacuoles should not have basal membrane. So this is very strange. So it means that the vacuolar membrane has like sarcolemmal features. This sarcolemmal feature can be confirmed also by immunohistochemistry. If you perform immunohistochemical analysis by using the antibodies against various sarcolemmal proteins, actually the all immunohistochemical analysis shows the vacuoles are positive. The presence of all those sarcolemmal proteins with onto the vacuolar membrane. For example, this is dystrophin N-terminal. You can clearly see the vacuolar membrane, right? So you can identify vacuolar structure. This is dysferlin, dystroglycan. So everything, maybe except for this is a little bit equivocal, the collagen 6. Collagen 6 is only one which is equivocal. Otherwise, all sarcolemmal proteins are present on the vacuolar membrane. So it really has sarcolemmal features. In addition to that, if you perform acetylcholinesterase, actually acetylcholinesterase activity can be also present, can be identified also in the vacuolar membrane. But the acetylcholinesterase is normally present at the neuromuscular junction, but this is not neuromuscular junction because if it is neuromuscular junction, there should be acetylcholine receptor, which can be identified by alpha-Bangalore toxin, but there's no structure identified by alpha-Bangalore toxin. So it means that this is not neuromuscular junction, and it is not accompanied by acetylcholine receptor. So acetylcholinesterase is the only acetylcholinesterase is present. And once you have acetylcholinesterase, of course, non-specific esterase can also detect it. That's why non-specific esterase staining also highlights the vacuolar membrane. Okay, so what does it mean? Actually, this is the illustration of the neuromuscular junction. And acetylcholinesterase and acetylcholine receptors are present on the muscle side, not the neuron side. So then this is the muscle fiber. In a sense, this is a sarcolemma in the neuromuscular junction. And this is the magnified version. And this is muscle fiber membrane or plasma membrane. Then you have basal lamina. And actually, acetylcholine receptor is, of course, it's a receptor which is present in the membrane, plasma membrane. But acetylcholinesterase is actually present in the basal lamina of the neuromuscular junction. So it means that the vacuolar membrane we see has sarcolemmal feature, but it is a unique sarcolemmal feature, which is very similar to the one we see in neuromuscular junction. But of course, it's not neuromuscular junction, but the feature is similar to this one. It has this structure, but not this structure. So that's why we name it autophagic vacuoles with unique sarcolemmal features. It's not just usual sarcolemma, but the unique sarcolemmal features. Yes, so which is they are autophagic vacuoles with vacuolar membrane, with sarcolemma proteins, all types of sarcolemma proteins, and the acetylcholine esterase activity. And on electron microscopy, again, we can identify basal lamina. So then the question is how these autophagic vacuoles with unique sarcolemmal features are produced. One possibility is actually it has sarcolemmal features. So one possibility is it may be produced by indentation of the sarcolemma. And indeed, we sometimes, not often, but we sometimes see this type of indentation. And actually, autophagic vacuoles looks like they look like are connected to the vacuolar sarcolemma. But if you examine all the autophagic vacuoles in this case by dystrophin staining, so you can follow all the vacuolar membranes from one end to the other end. But many of them, most of them actually never connected to the sarcolemma. This starting from this one and to this one, and nothing, no connection to the sarcolemma. If you see the longitudinal section, again, you can see from this end to the end, there's no connection to the sarcolemma. So it means that most of autophagic vacuoles with sarcolemmal features have closed space, never connected to, not connected to the sarcolemma. So it means that most likely, we still don't know how it is formed, but most likely, so the autophagic vacuole is somehow, for some reason, surrounded by membrane, new membrane, which is most likely synthesized de novo within the cytoplasm. And this AVSF is formed actually within the cytoplasm. Then sometimes this is connected to the sarcolemma afterwards. And that's why we sometimes see this one. This is still our hypothesis, but we don't know how and why this type of unusual structure is made. Well, then the genetic cause. So the LAMP2 gene actually has three isoforms, 2A, LAMP2A, LAMP2B, and LAMP2C. LAMP2A is ubiquitously expressed, while LAMP2B is mainly expressed in muscle and heart, while LAMP2C is expressed in brain. Most patients have mutations in the common region. Actually, the only difference with among those three isoforms is the last exon. So the last exon, I mean the exon 9 is alternatively spliced. So the exon 1 to 8 are exactly the same. And most patients have mutations within this region, the common region. So all those isoforms are lost. But rare cases have mutations in exon 9B, but not exon 9A, exon 9A or 9C. So it means that most likely the loss of LAMP2B is important to cause the phenotype of Danon disease, but not LAMP2A or LAMP2C, although we have to wait to have more patients to be concluded. So LAMP2 is the major lysosomal membrane glycoprotein, and they are rich. There are a lot of LAMP2 proteins on the lysosomal membrane. But we still don't know and there is another one, LAMP1. And LAMP1 and LAMP2 are really homologous. And many people think that there must be some functional overlap. Actually, we still don't know the exact function of the LAMP2. But one plausible hypothesis is that because it is rich, there are a lot of LAMP2 proteins in the vacuolar lysomal membrane. Probably this somehow protects the lysomal membrane and also lysosome itself. Or there are actually some evidences that this LAMP2 is somehow associated with lysosome fusion of lysosomes with autophagosome or phagosomes. And also this is associated with migration of lysosomes. And so some people say that we know that lysosomes move along the microtubes. So for this movement, you need LAMP2. That's some papers suggested. And also another function is some people claim that there is a direct uptake of some certain proteins or even the RNA or something into the lysosomes. Through this is mediated by LAMP2A or LAMP2C. And this one mediated by LAMP2A is called chaperone-mediated autophagy, CMA. So again, this is the list of the patients we initially identified, in whom we initially identified mutations. So there were 10 patients, but again, interesting, one patient actually had mutation in exon 9B, but all other patients had mutations between exon 1 to the common part. But this one affects only LAMP2B theoretically. But all patients actually have more or less the same phenotype. So it means that, again, LAMP2B is the main cause of the phenotype. And again, because there's not much difference between those patients, majority of the patients who have mutation in the common part, and this rare patient with the mutation in the affecting the LAMP2B isoform only. There is not much difference in terms of phenotype. So it means that probably chaperone-mediated autophagy it's not probably not so important in our to maintain our the function of our body. Because if their CMA is plays a very important role in our body, so those who have mutations affecting LAMP2A isoform should have more severe phenotype, much more severe phenotype, but actually the difference is very, very mild. Okay, so again, as I mentioned, LAMP2 is deficient. LAMP2 protein is deficient, which can be identified, which can be shown by, demonstrated by immunohistochemistry or Western blotting. So this shows immunohistochemistry. As you can see, LAMP2 is present in the lysosomes. So you can see the dot-like structures within the cytoplasm, but nothing is usually stained in Danon disease patients. And this can be also confirmed by Western blotting. And this, if you remember, patient 1 has mutations in exon 9B. It means that patients LAMP2B is affected, but LAMP2A and LAMP2C are not affected. This is actually from the skeletal muscle. So LAMP2C is known to be present only in the brain. So, but you can see this, there is a trace positive, faint band here. So this most likely is LAMP2A. So you see the trace amount of LAMP2A expression in the skeletal muscle. So this patient actually has a little bit milder symptoms as compared with other patients. But again, the phenotypically very similar. So the mechanism of the disease, we still don't know, but the one possibility is because the LAMP2 is believed to function in autophagosome lysosome fusion. So maybe this defect in the fusion is the pathomechanism of the disease, or a lysosomal movement itself, maybe the cause of the disease. But at least from our study, we can say that CMA, chaperone-mediated autophagy, doesn't play an important role, and nothing to do with the phenotype of the Danon disease. Okay, then another the important disease is an X-linked myopathy with excess of autophagy, or XMEA or XMEA. This is caused by mutation in BMA21 gene, which is also located in X chromosome, the long arm of X chromosome, just like Danon disease. And so far, this is actually rare condition, and so far 14 mutations are reported. So it seems like this is more rare than Danon disease. And so far, no genetically proven female the manifesting carrier have been identified. So far, only males are affected. This is different, very different from Danon disease. Again, in Danon disease, female carriers, actually most of them develop some symptoms, and sometimes very severe, as severe as male proban. But in XMER, no female carriers develop any symptoms. And the main difference between the Danon disease and XMER is this one: no cardiac involvement in XMER, while cardiomyopathy is the very important clinical feature of Danon disease, which actually causes death in patients. Because there's no cardiac involvement, seems like their life expectancy is not that bad. So we still don't know how long they can live, but many patients are actually still ambulant even after age 60s, and they live much longer than Danon disease patients. So this is muscle pathology. So the muscle pathology looks actually very similar to Danon disease. Again, you can see like a granular basophilic, granular structures. They are actually tiny vacuoles, tiny autophagic vacuoles. And acetylcholine ester, you can see acetylcholine esterase activity onto the vacuolar membrane, just like Danon disease. So, but the main difference in terms of the electron microscopy is the basal laminar structure. Of course, you see this type of autophagic vacuoles. Actually, this is more or less somehow similar to Danon disease, but the basal lamina is different. You can see many layers of basal lamina. And between basal lamina, it looks like there are autophagic materials inside. So it looks like they want to exocytose those autophagic vacuoles, autophagic materials outside. But yes, there is exocytosis. But looks like they are, I don't know, but they looks like they are poisonous or toxic, to the extracellular space, and so that's why the basal lamina don't want those materials spread widely. That's why they want to prevent the spread. I don't know, but there are many layers, and it looks like preventing the spread of those materials. Okay, so the BMA, what is BMA21? BMA21 is an assembly chaperone for the complex of vacuolar ATPase. Vacuolar ATPase is the ATPase, the pump, the present in the lysosomal membrane, and which actually pumping in the proton and maintains the acidity of the inside the the lysomes. So this is important. This vacuolar ATPase or VATPase is an important structure, maintain the acidity of the lysomes. And to make this one, actually there is V1 and V0 complex. And to assemble this V0, you need this VMA21. So if you have problem, if you have mutation in VMN21, most likely you have problem assembling this V0, then this vacuolar ATPase. And again, vacuolar ATPase pumping in the protons, and this is how they maintain the acidity of the intraluminal space within the lysomes. And in fact, in patients with eczema, actually the pH, lysomal pH level is increased as compared with control. Increased pH means acidity is lost. It's more alkaline. So this is compatible with the mechanism, hypothesized from the mutations in VMA21. Interestingly, the typically patients develop disease after age 10 or even 20s, but there are rare congenital cases or very severe forms. These two brothers are actually, they had problems since birth. And actually many of their uncles die immediately or within several days after birth. So actually they had almost the same symptoms. They had severe symptoms, respiratory failure or whatever, but they survived probably because of the development of the management and care system. The neonatal, thanks to neonatal care. So they survived, but they have severe weakness and muscle atrophy like this, and facial muscle involvement. Yes, and we identified actually later we identified the VMA21 mutation, and then now we know that they have a severe form of eczema. But again, of course, their muscle is severely affected, but their brain function is completely normal, and their cardiac function is also completely normal. So they can survive. They are in their 20s at the moment, and those brothers actually work as, the elder brother is working as an artist who is actually a cartoon artist like this. And the younger brother is actually professional DJ like this. And he needs respiratory support, but he does DJ work like this. Okay, so then how about muscle pathology? Again, the same. So although you see more remarkable fiber size variation with endometrial fibrosis, and it looks a bit more like dystrophic, but still the nature, pathological feature is the same. You can see acetylcholinesterase onto the vacuolar membrane, and it has the sarcolemmal feature can be confirmed by dystrophin staining like this. So on electron microscopy, you can see a lot of phagocytosed material within the vacuole. And if you take a closer look at the vacuolar membrane, you can identify basal lamina. So the nature is very similar, in a sense, very similar to Danon disease. And again, looks like they try to exocytose those material, but you see there are multi layers of basal lamina. Looks like they try to prevent this one to come out. And then how these vacuoles are made, of course, we don't know, but these double immunohistochemistry with LC3, which is a marker of autophagosome, and LIMP1, which is a marker for lysomes. And in Danon disease, there's not really co-localization of MC3 and LIMP1. So it means that maybe they are not really fused. But in Xmea case, you see there you can see yellow color. It means that they are co-localized. So maybe, of course, we don't know, but maybe one possibility is that in Danon disease, the fusion is somehow affected. So maybe there is some problem here. But in Xmea, because they are already co-localized, probably the abnormality is here. Because this may be compatible with the fact that they have abnormality in the acidity. So lysosomal function is decreased. So that's why after the fusion is okay, but the digestion, they have problem in the digestion. So maybe compatible. Okay, so finally, I'd like to highlight this paper. This paper was published in a couple of years ago by Professor Gayathri's group. And clearly, this is as far as I know, this is the only autophagic vacuolar myopathy reported from India. And you can see the beautiful electron micrograph here. And I believe that autophagic vacuolar myopathy cannot be identified and diagnosed without well-experienced and highly knowledgeable pathologist and the high-quality laboratory setting. So this paper actually shows an evidence that how high the quality of the muscle pathology diagnostic system in NIMHANS is, which is actually established by Professor Gayathri's great efforts. So I'd like to congratulate Professor Gayathri for the establishment of the reliable muscle pathology diagnostic system in NIMHANS and India. And I hope you will still keep contributing to the field by teaching young staff, although maybe in a more relaxed way. Thank you very much for your attention.
Say some words.
Dr. Nishino, thank you very much for that lucid presentation and telling us about the differences, both clinical, pathological, including the electron microscopy of Danon's disease as well as the Xmea. So thank you very much. You also helped us with our Xmea. I sent you the photographs. We also discussed the case, and then you were the one who sealed the case for me. Thank you very much.
Thank you, sir, and thanks, sir, for chairing this session. We'll now move on to the next lecture by Dr. Thangaraj on neuromuscular disorders of mitochondrial origin. And I request Dr. Sundara to chair this session and introduce the guest speaker.
Good afternoon, everybody. It's my pleasure to invite Dr. K. Thangaraj, who is a director for Center for DNA Fingerprinting and Diagnostics, and also Chief Scientist and Group Leader, CCMB Hyderabad. I have a long association with him because of our mutual interest in mitochondrial diseases. He has many awards and honors to his credit. He is an elected fellow of the Indian Academy of Sciences, the Indian National Science Academy, and National Academy of Sciences. He is a recipient of J.C. Bose Fellowship, Raman Research Fellowship, Sun Pharma Research Award in Medical Sciences, Lifetime Achievement Award, Excellence in Science Award, Distinguished Scientist Award, Dr. Subhash Mukherjee Oration Award, Professor G.K. Manna Memorial Lecture Award, and many others. His major areas of interest include origin of modern human, cardiovascular diseases, mitochondrial disorders, and male infertility. He has more than 250 publications, and it is my pleasure to invite him to deliver a lecture on neuromuscular disorders of mitochondrial origin. Thank you. Welcome, Dr. Thaniraj.
Thank you, Professor Sundaram. Good evening, all of you. I feel it's a great honor for me to be part of this great event organized in honor of Professor Gayatri, whom I know for several years because of our common interest in the field of mitochondrial disorders. And our collaboration has gone a long way, not only led to a project from DBT, and also we obtained project from multinational project funded by MRC. Some of you are aware of that. And in addition to the scientific collaborations, she also involved very effectively in supporting the organization which you have called Society for Mitochondrial Research and Medicine. So that tells that how committed she is in the field of mitochondria, and it's once again great honor for me to be part of this event and deliver a talk. As I mentioned that we have a common project that in fact was inaugurated in the House of Lords in UK Parliament after the program. This is a photograph with all the PAs. So with that, I'll go ahead with my talk. After getting to know that Dr. Bindu is also speaking on similar topics, so I thought it would be a good idea to change my topic. So I'll not talk much about mitochondrial involvement in case of mitochondrial disorders, but I will focus more on the nuclear genes that are involved in mitochondrial disorders. As many of you are aware, mitochondrial disorders are very, very complicated. It affects almost all the organs. You can see that almost all the organs have shown here have been is a potential target for mitochondrial disorders. And earlier we know that the mitochondrial diseases are affected only by mutation in the mitochondrial DNA. So we thought that mitochondrial diseases are maternally inherited, but now we are seeing large number of nuclear genes are also associated with mitochondrial disorders. So we can say it's a dual origin, mitochondrial as well as nuclear. So it also follows the Mendelian inheritance. This, you know that in the mitochondrial subunit, a large number of nuclear genes are involved. As you know that even more than the mitochondrial encoded genes, there are large number of nuclear genes are involved in all the subunit, all the mitochondrial subunits. So that's very clear that large number of nuclear genes are involved in mitochondrial disorders. So we have been working on this field for last several years, of course in collaboration with NIMHANS, NIMS, recently with AIMS. So far we have analyzed more than 1,000 samples, and you can see that these are variety of disorders which are associated with mitochondria and mitochondrial associated nuclear genes. These are the neuromuscular disorders. And the names, as you know, that is very, very long because of the multi-syndromic impact. You see that LAN, that means Leber, hereditary optic neuropathy, chronic progressive external ophthalmoplegia. So it goes on like that. So we have initially analyzed all of these cases with complete mitochondrial DNA sequencing, and we found large number of cases are associated with mitochondrial mutations, but still there are large number of cases where there's no clue from mitochondria, although there are evidence that these are mitochondrial disorders. And you can see this photograph. The father has CPO, that's a chronic progressive external ophthalmoplegia, and his elder son was normal like this younger one at the age of 5, but you can see there's a slowly the symptoms are appearing here, but we don't know the fate of this child. So this shows that there's a definite nuclear involvement. Now we cannot only say that mitochondrial disorders are maternally inherited, there's a strong paternal inheritance also exists. And these are some of the candidate genes which are known earlier. This POLG, the polymerase gamma, is one of the genes which is essential for mitochondrial DNA replication. So if there is any error, any mutation in the gene, it will lead to multiple mitochondrial DNA deletion and leads to variety of phenotype. This is one example where you can see this single base mutation in polymerase gamma 1, which leads to encephalopathy, seizures, and stroke-like episode. So what is interesting here is that there are two families, and both the families, parents are heterozygous for this mutation. This is a wild type C, this is a heterozygous C and T, and this is a complete mutant T. So with the parents with the heterozygous mutations are absolutely fine even at the age of 45. But it's unfortunate that the two of their children have received one abnormal chromosome from father, one abnormal chromosome from the mother. Therefore, it's a homozygous mutation here, which leads to very early death. So you can imagine the situation of the family. So this I'll come a bit later towards end of my talk. That so what is the situation? Why it exists like this? This is of course the consanguineous family. In the non-consanguineous family, also you are seeing similar trend. So the couple of children, both of them have died, and both of them are with homozygous mutation. So this is another very large pedigree. What you see here is that many individuals in this family, in this large pedigree, have died because of the mutation in the polymerase gamma 2. 3 families here. It's very large family one. This has a neuropathy. This family has a CPO. This is also with the CPO. And this is very highly consanguineous, where you see there are 3 families. All the 3 are with multiple mitochondrial DNA deletion. That's because of single base mutation, the wild type, heterozygous, and complete mutant. And of course, the histopathology shows the COX negative fiber. And this is the case where we try to understand how the mutation is distributed all over India. In this case, where we have seen that this particular mutation in heterozygous condition is distributed all over India in about 4%. Okay. So this is not surprising because we already seen similar trend in India. This is one of our mutation, which I will come a bit later. When we try to understand its existence, at least in the HapMap samples, we'll see that Africans doesn't have the mutation, American doesn't have the mutation, East Asian, European, none of them have the mutation. Whereas in South Asians, you have up to 4%. Okay, this is from the database where the data is existing. So as I mentioned, that it's not very surprising for us because we have seen similar trend in one of the gene called myosin binding protein C3 gene, which the mutation which leads to 3 different kind of cardiomyopathies: hypertrophy, dilated, and restrictive cardiomyopathies. All of them leads to a sudden cardiac death. And when we looked at, again, the heterozygous mutations are distributed, it's a 25 base per deletion all over India in about 4.5%. When we try to look at sample from worldwide, we did not see the mutation other than South Asian countries. So this mutation is restricted to only in South Asia. So we have earlier this information, therefore it's not surprising to us. So then we went on to going ahead with exome sequencing, because most of the genes that have been reported so far has not given any clue for large number of cases. So we went on to do exome sequencing. This is one of the recent ones. So we have different set of samples and different set of exome data. So this is one again in collaboration with Nimhans and Manipal with Professor Satyamurthy. So where we have identified the MELAS cases, that's a mitochondrial encephalopathy, lactic acidosis, stroke-like episode, with the classical mutation that's at the nucleotide position 3243 A2G. We sequenced about 11 samples and we found that large number of nucleate genes that are associated with various diseases, including mitochondrial encephalopathy, sensorineural hearing loss, diabetes, epilepsy, seizures, and cardiomyopathy. So these are those genes. And of course, I don't have to tell much about brain MRI and histopathology. So this tells that even though there's a mutation in the mitochondrial DNA, still there's a possibility of having nuclear gene mutation. So we cannot leave the nuclear gene mutations. And these are some of the nuclear genes which we identified by exome sequencing. And one case where you see there are some unique features. In this case, there's an individual with chronic progressive external ophthalmoplegia and premature aging, where you see complete absence of hairs in the eyelashes and eyebrow, and also this loss of hair on the side. And he's only 20-year-old, but you can see that he appears like about 50-year-old man. So again, leading to premature death. The mutation in C10ORF or twinkle, where again this is heterozygous mutation, which leads to again multiple mitochondrial DNA deletion, suggesting that nuclear genes are very important in causing such diseases. This is another gene, DHTK1, again leading to multiple mitochondrial DNA deletion. And what is interesting, you have to keep that in mind, is most of them, which I'm demonstrating here, are autosomal recessive mode of inheritance, where you see that the one who has the homozygous mutations like this is a patient with AA, and parents are with heterozygous A and G, and this is the wild type G. So wherever you see that the homozygous mutations are the one which leads to the disease. Again, the histopathology shows that ragded fiber, COX negative fiber, and so on. This is another gene where you see that NDUFA5 patient with Leak syndrome, the large pedigree here, and this is once again you can see the parents are heterozygous, wild type, one chromosome with wild type, one with mutation, and the child with homozygous mutations, which is shown here, are the one which are having the disease. So it's clearly large number of cases are following autosomal recessive pattern of inheritance. This is another example with SLC25A46 gene. Once again, you can see that similar trend. There's another gene, BCSL1L. Again, the same trend with the homozygous mutation leading to the disease. This is yet another gene where once again you see there's an insertion of the T. Of course, this is not following the autosomal recessive pattern of inheritance, but whereas large number of them are following this trend. This is another case where the same gene, TIMP1, Again, it follows autosomal recessive, control, parents are with heterozygous mutation. And this patient, you can see the phenotype with MNGIE, that's a mitochondrial neurogastrointestinal encephalopathy. It's a very long name. And there's a loss of muscle and many more phenotype. And we try to develop animal model, particularly with zebrafish, where you can see we knock down using a morpholino, and this is a control, and the knockdown one, and you can see, compare the phenotype of the zebrafish and the patient, where you see clearly loss of muscles and edema and many more phenotypes. Sometime you also find that there's a biallelic mutations. So in the same gene, there could be two different mutations. Again, one of the parents might have one mutation, what you see here, mutation at 454 T2A in the father. The mother has mutation at 421, where unfortunately you can see that both the mutations have come to one child with the disease, whereas the other child is heterozygous and he is absolutely normal. So we'll have to look at different aspects in genetics. As I mentioned, mitochondria, nuclear, whether it's homozygous or heterozygous or biallelic or bigenic, and many more aspects. So as we go along, then we try to get much more information on various aspects. So now I'll give you different perspective, taking that considering where a lot of people are migrating from India to other countries, or vice versa, where you expect that some of the people who carry the founder mutation to other countries, what happened there? So this is one of the interesting case where one of our collaborators in UK, Robert, this is how we started the collaboration. So he one day wrote a mail saying that he has 3 patients who have come from India, and they have a very specific mutation which is not found or reported in UK. That's in the RNase-H1 gene. In fact, they initially tried to analyze the known genes which were found in UK population, but they could not find. They did exome sequencing and found this mutation in this particular gene. And when he asked me to check whether our sample has that, we tried to do, but we did not find the mutation in our collection of sample. Of course, our samples have come from NIMHANS and NIMS, mostly from South. Then I asked Rob where from India they have migrated. He said they have migrated from Gujarat. Of course, I know that you expect the population specific variations because of the population structure and the endogamy marriage practice in large several thousands of years. So, so that clearly shows that there's an ethnic difference, not only different countries, even within the country, you have different population might have different set of mutations. So this actually very well fit with the mutation which I showed earlier, that a large number of mutation which we observed are autosomal recessive mutations, where we few years back we came up with this kind of conclusion by analyzing large number of populations, sample 2,800 individuals from more than 250 populations, and we came up with the view that there could be large number of population specific recessive mutations in Indian subcontinent, not only in India and also in South Asian populations. So when we analyzed these samples, we found that at least 1/3 of the populations in India or South Asia are having high IBD score. That means identity by descent. That means that in simple way, if you compare a large such of DNA sequence from 2 unrelated individuals, And if they are really unrelated, then you see a lot more variations. But if they are related, even several generations back, you don't see much variation. The haplotype will be the same. So in that way, when we analyze and found that large number of population in India, at least 1/3 of the populations are actually emerged from a common founder. So that's what is shown here. What we see that every line represent one population, and the red ones are Ashkenazi Jewish and Finnish population. You can imagine that with this tiny IBD score itself, they have large number of diseases have been mapped, which I'll show in the next slide. But imagine that large number of Indians are several fold higher IBD score, and you can imagine that what would be the consequences of a lot of Indian populations. So that is what, if you identify any mutation, if you go into the population, you may able to find large number of such mutations. I mentioned this couple of population, Ashkenazi Jewish and the Finnish population, where you see in Jewish population large number of diseases, and the large number of diseases has been mapped, genes have been mapped, and most of them are autosomal recessive in nature. Similarly, in Finnish population. So how to explain that? So that if you look at the pedigree, for example, in this case, husband and wife, where you see this is a mutation, consider that's autosomal recessive mutation. Therefore, there is no disease here because it's existing the heterozygous condition. But if they marry, even their children will not have the homozygous mutation because it goes generation after generation only in one of the chromosomes, unless otherwise they marry somebody with the same mutation. Okay, it goes generation after generation, right? So after several generations, they have lost their relationship this way and this way, and now they are in the same population, but they come from the same founder. And when these two decided to marry, considering that they are unrelated, but they are in the same population, both are carrying the mutation heterozygous condition, and if they marry, there's about 25% of chance of getting some similar disease. So that is what I mentioned earlier. Large number of cases where we found mutation with which is found in homozygous condition, where the parents are heterozygous, must those mutations must have come from a common founder. To test that or to connect whether it's really true, so we took one of the disease called progressive pseudo rheumatoid dysplasia, which is caused by mutation in WISP3 gene. Parents are heterozygous in about 30 patients which we analyzed, and the patients are homozygous. The age of onset for the disease very early, where you see that about 30 patients, when we sequence, 6 of them carry the same mutation. When we sequence the flanking region to understand whether all the 6 are from the same founder, we found 5 of them are having the same haplotype, suggesting that they are, although they are telling that they are unrelated, but actually they have come from the same common founder. So that is very, very significant in large number of Indian populations. So with this, what we need to do is that something like the Ashkenazi Jewish population practice. They have a community organization called Doreshim. This organization goes to school, collect the sample from the children, the sequence, and put it in their database. When anybody, either boy or girl, when they grown and when they're ready to marry, the boy says that he wants to marry any girl or the same way the girl, but they take out the sequence, compare and see whether both of them are carrying the same mutation. Although they know that because they have sequenced large number of individuals with the disease, they identify the mutation, they identify the disease. Therefore, they can able to tell or give counseling whether to marry or not to marry. Even if they are marrying, this is a mutation, you need to keep eye on that and do the prenatal diagnosis, so on. In fact, by doing this, they have eliminated a couple of disease from the population itself. So in that way, we are now in the process of taking some of the patients with the population-specific disease like this Handikudu disease, you know that they are in Shimoga district, place called Handikudu, with start stature and bone abnormalities. There is another case, the population-specific disease and the regional-specific disease called Udanam kidney disease, and there are some of them are listed here, which are population-specific disease. And we are also taking the sample where we found high IBD score, where we don't have phenotype, but still we are taking, considering the fact that there could be some population-specific mutation, otherwise it would not have shown such a big IBD score. So that is our current research, apart from what we are doing in the field of mitochondrial disorders. So with that, I'll stop my talk by acknowledging all those who have involved in this study. From my group, Paramaswamy Manniyarajan Govindarajan is already there. Rajan is my another student, Nahid, Lalja Singh, who was supported for many aspects. NIMS, unfortunately, we lost Dr. Meena, another wonderful collaborator. Of course, Dr. Sundaram is there, who introduced me. From Shankar Nethralaya, NIMHANS, of course, Dr. Gayatri, Dr. Chali, Bindu will be talking after me. Madhu and Satyamurthy and Gopinath from Manipal University, of course. Keshav is always there with us, Rob and many others from UCL London. The funding has come from DBT, CSIR, DST and MRC London. With that, thank you very much, and I hope that Dr. Gayatri will continue her support for us in the field of mitochondrial genetics. I am seeing her nodding her head. Definitely, yes. Thank you. Thank you very much.
Thank you, Dr. Tangaraj. Very beautiful lecture. Actually, you have brought out the complexities in the diagnosis of mitochondrial diseases. It's very interesting to see how you mapped the mitochondrial diseases based on the migration of the populations. It is true that we carry our genes wherever we go. It's very nice lecture, and thank you very much. And best wishes to you, Gayatri. I'll talk to you later. Thank you very much.
Thank you.
Thank you, sir, for such a wonderful lecture, and thank you, madam, for chairing this session. Now we come to the last lecture of the symposium, a very interesting lecture by Dr. P.S. Bindu on mitochondrial research at NIMHANS from bedside to bench and back again. I request Professor Tally to chair this session and welcome the guest speaker and introduce.
Thank you. I think first and foremost, I would like to thank the Department of Neuropathology and Professor Isha to give me the privilege of being here for this wonderful occasion. It has been a great experience to work with Madam Gayatri. I never said Professor Gayatri or Gayatri, but Madam Gayatri. I think there are certain things which have not come out, despite I'm running out of the words, whatever I have heard from others about Madam Gayatri. She has 3 A's. She has ability, she has availability, and she has affability. All conversations with her are very reflective. Absolutely, you can talk to her without thinking that what will be the repercussions like. And many of us who have worked with her, whenever you approach her for a scientific issues, she will say what you need. She will never ask why you need. So that is my experience with her. And then I think she has been involved in the training of one generation of the DM residents and the PhD scholars. And for all we work together with her, she is a symbol of dedication, commitment, care. And her vision has brought the mitochondrial work to the present height that we have heard from others also. And I think it has been a wonderful experience, madam.
Thank you so much.
Thank you very much for your unconditional support
that you had given me.
Unconditional support to the neuropathology of the muscle and the associated diseases. Thank you very much. Now I have the privilege on present duty of introducing my colleague, Dr. P.S. Bindu. She is currently at New South Wales, Australia, and she is serving as staff specialist pediatric neurologist, Liverpool Hospital. She was for a brief period as a former clinical senior lecturer at University of Sydney. She had a long association with us at NIMHANS, and nearly 15 years she has served as a faculty colleague at different positions. She was known for her passionate care for the children, and over a period of time she developed interest in the mitochondrial research. And she would pose a question and Madam Gayatri would come to the occasion, raise to the occasion to solve. And I think what she is going to share is her dedicated work in the field of mitochondrial disease with us. It's nice to learn that even after going to Australia, she is still attached with the mitochondrial disease and carrying forward the work that she has done here. Dr. Bindu, please deliver your talk. And I think the topic is very, very apt to pay tribute to Madam Gayathri, NIMHANS work in the area of mitochondrial disease.
Thank you very much, sir, for this generous and kind introduction. It is a great honor to be here today in this symposium in honor of Professor Gayathri, and it is indeed a privilege to speak on the mitochondrial research at NIMHANS, which Dr. Gayathri has so passionately led and nurtured. And I thank Dr. Yesha and team for giving me this opportunity to give this talk. And I would like to start with this sentence, like the clinical maze of mitochondrial neurology. For a diagnostic evaluation of the mitochondrial disorders is like negotiating a maze. It is very complex, and in a neurology setting, it is said that either they are underdiagnosed, what is this bizarre syndrome, or they are overdiagnosed. This syndrome is so bizarre that it must be mitochondrial. And they are very easy to suspect, but very difficult to establish because of the inherent complexity, clinically seemingly disconnected clinical features affecting multiple organs, benign onset, they can have oligosymptomatic presentation, and the huge heterogeneity at multiple levels like clinical, biochemical, genetics, or phenotype MRI levels. At every level, there is heterogeneity. And different family members presenting with the different phenotypes, and the clinical overlap with other neurogenetic, metabolic, and non-genetic diseases. At almost any other diseases can mimic a mitochondrial disorder. So are there any Ariadne's threads that can direct the modern day neurologist, if not to the correct diagnosis, but at least to the likely disease category? I would say that the most important thread is the interface between the basic science or the lab, the research scientist, and the clinicians is one of the important thread. And in the next 25 minutes or so, I will try to narrate this journey of the successful collaboration or the interface between the clinical team and the neuromuscular lab or the neuromuscular and the research scientist in NIMHANS in the field of mitochondrial medicine. So the beginning was a very humble beginning in 1988 with a study on floppy infant syndrome by Dr. Anisha Vasant under the able guidance of Professor Gauri Devi, Professor Sarladas, and Gayatri Madam on floppy infant syndrome, which included 36 patients, and of those patients, 4 had a clinical diagnosis of mitochondrial disorders. And if you look at it, it's very interesting to read the meticulous clinical description of this patient, a 12-year-old boy with motor delay, seizure, and the proximal muscle weakness. All these clinical features very nicely depicted or demonstrated in this.
Madam, sorry to disturb you. Are you sharing the screen, madam?
Yeah.
No, it's not shared.
It's not seen.
Okay, can you please? Yeah.
It's enabled. It's enabled, Bindu.
It is enabled, but.
Just reshare it.
Okay, I will reload it. Yeah.
Can log off and
yeah, you can stop sharing and again you can reshare.
Okay. It is showing it is disabled attendee screen sharing.
Okay. And now you try it again.
Yeah. I am seeing it now. Can you see that? Yeah. Okay. I'm sorry about that. So this is my first slide on clinical maze of mitochondrial neurology, and then the complexity of mitochondrial disorders and the threats which can lead to the diagnosis for of the mitochondrial disorders. And this is the current slide which I am talking. Yeah. So it is a study on the floppy infant syndrome and 12-year-old boy with mild motor delay, seizures, ptosis, and proximal muscle weakness, which is very nicely depicted in this picture. And the diagnostic confirmation was by the histopathology and the electron microscopic studies. And next, the 2001, we had the spectrum of neurological disorders, the DM thesis by Dr. Manjunath NC, on spectrum of neurological disorders associated with mitochondrial cytopathies, which included 45 patients. The diagnostic basis was still the muscle histopathology and electron microscopy, had a definite and probable mitochondrial disorders. And in this disease also, if you go through it, it is very interesting to note that so many descriptions or the features described in this disease have been highlighted later in the literature on mitochondrial disorders, like dystrophic features in patients with CPO and mitochondrial cytopathy. So from those humble beginnings in 1988 and 2001, the problem was with the over-reliance on the clinical syndromes and the histological features, misdiagnosis, particularly non-syndromic presentations, and over-diagnosis because of the secondary mitochondrial changes. We needed to move forward. And from morphological diagnosis to step forward for to the molecular diagnosis in 2006, as Dr. Thangaraj mentioned, the multi-center DBT-funded project on study of mitochondrial mutations in neuromuscular disorders was initiated by the team of Dr. Gayathri, Dr. Thangaraj, and Professor Talley. And we had a series of research questions, newer tools, some answers, more questions, and ongoing work and dedicated team which came in. So from the humble beginning, we had a steady progress over the next decade or so. This was possible because of the dedicated team comprising of the DM neurology trainees, the PhD students, and the faculty in both neuropathology and neurology, spanning from 2010 to 2019 and still going on. So the first study was, we tried to analyze the clinically suspected patients, 320 patients with a clinical diagnosis of mitochondrial cytopathy who underwent the whole mitochondrial genome sequencing as part of this DBT project. And it showed the study brought up mitochondrial DNA mutations in 105 patients, 75 children and adults 30. But the problem with this study was that majority did not have mitochondrial DNA mutations, and others had either novel variants or some had reported mutations, and the plethora of clinical features as in patients and any mitochondrial disorders, and the different mode of inheritance. And this is done by Dr. Govindaraju. And the challenge was, the good point was, it was a large cohort, the first cohort evaluated and followed up at NIMHANS, and the first and largest of its kind from India. Variable and non-specific clinical manifestations across all ages, but most of them remained probable or possible. And the diverse genetic variations with overlap phenotypes, some had classical syndrome and recognized mutations, some had classical syndrome but novel mutations, non-syndromic phenotype and recognized mutations, and some had both non-syndromic phenotype and novel mutation. So there was a felt need for the validation of this causal role of the novel mutations. So the way forward was, we need to develop some kind of functional analysis to validate these mutations. And so we tried to develop these functional assays, and one of this was the Oxford spectrophotometric enzyme assays. And this was done by our bright and enthusiastic PhD student in clinical neurosciences, the Dr. Sonam Kothari. She spent 5 years in standardizing and validating this respiratory chain complex assay. And there were practical issues in establishing this assay because it was the first time validated in India, and standardization was a little difficult, and we did get input and guidance from mitochondrial research group in Newcastle. Sonam went there and stayed there and tried to validate her methodology and standardization with the lab. So the cohort included both children and adults, and the children, 182 patients, 109 children, they showed respiratory chain deficiency in 85 patients, which were complex 1, 3. The most common was complex 1, followed by multiple complex deficiencies. And the adult patients also had the similar picture. And there was a detailed analysis of these both groups. The children were studied by Sonam, and the adult patients with respiratory chain disorders were studied by Dr. Rakesh Kumar, DM trainee. So the complex deficiency was the most common deficiency as reported in literature. The commonest phenotype was Lee or Lee-like syndrome. And in multiple complex deficiency, the majority were non-syndromic. And in complex 4 deficiency, we had most of the patients with Lee syndrome and SERF1 mutations. But still, the mitochondrial DNA sequencing done in 112 patients of this cohort showed point mutations only in 18 patients. And the reported mutations in 5 and novel in 3. And still it was, and we did a selected nuclear gene sequencing in the cohort, the SERF1 and POLG1. And so the vast majority did not have the point mutations in mitochondrial DNA. So the also spectrophotometric enzyme assay has its own limitations. The normal ranges are difficult to define, matched controls are difficult to collect, and they're all continuous data, and the data are prone to secondary effects. And the many enzyme defects show tissue specificity, and some defects show age dependence, and enzyme assay limitations include the varying protocols used in different labs, and it is very difficult to compare the results between the labs too. So it was the first large cohort from India with who underwent respiratory gene assay and improved diagnostic yield compared to the histological studies alone, and provided pathogenicity, some pathogenic evidence for the novel mitochondrial DNA point mutation. And as I told you, it is only a small fraction of the patients had mitochondrial DNA mutation. So what is the next step? Look for the genetic abnormality in nuclear genes encoding mitochondrial function, because more than 75% of the children usually show the mitochondrial nuclear gene mutations, which accounts for the 99% of the mitochondrial proteome. Of the total mitochondrial proteins, more than 1,500 proteins reflect the diverse function of the mitochondria. And there are more than 300 pathogenic variants in over 300 disease genes currently described, and more than 50% discovered in the last decade too. But we did not have the exome sequencing at that time to sequence all the nuclear genes. But from our experience, the chronic progressive external ophthalmoplegia, CPO group, was the predominant phenotype, and we thought we are missing the deletions, and sometimes the single deletions can be the molecular abnormality in patients with CPO, and most of them had POLG or the mitochondrial DNA maintenance disorders with multiple DNA deletion. So it affects the intergenomic cross-talk pathways, and so we undertook a study on the mitochondrial intergenomic communication disorders, again by Dr. Shweta Chiplumkar, PhD in clinical neuroscience student, who spent 5 years on standardizing and validating the long-range PCR for the mitochondrial DNA deletions. She analyzed these deletions in 530 samples, and it was 10% of these samples showed deletions, and both single deletions and multiple deletion. She also standardized the qPCR for analyzing the mitochondrial copy number to analyze the depletion, because the mitochondrial intergenomic communication disorders can produce either multiple deletions in older patients and deletions or the depletions or the reduction in the mitochondrial copy number in the younger age group or infants. So this she did the mitochondrial copy number in 60 patients, and 20 showed the mitochondrial depletion, And some of the patients underwent exome sequencing, and it revealed various heterogeneous genetic mutation. And she also analyzed the polymerase gamma mutation because the phenotype was more of the CPO group and multiple mitochondrial deletions. And this was recently published by Dept and under Dr. Gayathri's guidance in the Journal of Molecular Neuroscience in 2021. It showed a span of mutations in which is spanned across the entire gene. And we had the reported mutations, which is the PL30R mutation, which is the commonest mutation reported from the Asian patients, and also novel mutations. And the clinical features were more or less similar to those reported in literature. So we have now the well-characterized large cohort with respect chain complex deficiency, mitochondrial DNA deletions, depletion, but underlying molecular basis in majority remained unknown. And so the single sequencing of the single genes, POLG and SURF, had a limited yield. So the sequencing of panel of nuclear genes encoding mitochondrial structure and functions were undertaken, the exome sequencing. But we did the clinical exome sequencing in patients with the help of an ICMR funded project, and it revealed mutations in almost all components of the mitochondrial proteome or the mitochondrial causing dysfunction, like complex 1 genes, 4 genes, assembly factors, complex 3 genes, and mitochondrial DNA maintenance genes, and other nuclear DNA genes involved in mitochondrial functions like ion cluster biogenesis gene, and also the SERAC1 in the cholesterol metabolism, PDHA1, and then we had the non-mitochondrial genes, the patients had the mitochondrial mimics, and some of them remained still unknown. So during the same time, since we had some evidence and the pathogenicity, we tried to publish. It's mainly on the clinical aspects and the mitochondrial neurological aspects of the mitochondrial disorders. And I will try to narrate a little bit about each studies. And one is magnetic resonance imaging correlates of the genetically characterized patients with mitochondrial disorders. And we explored the extent and pattern of CNS injury in these mitochondrial patients, and we did not have many with the confirmed mutations and mitochondrial point mutations, deletions, SURF1 and POLG. We did not have the results of the exome sequencing when we did this study, and it showed a plethora of findings, the magnetic resonance imaging finding. We did try to correlate the mutations with the genotype, phenotype, MRI phenotype with the genotype. And the follow-up scans showed progressive changes either in the form of volume loss in the involved structures or appearance of the new anatomical lesions. There was some correlation with the MRI changes and the prognosis of the patients. And there was another study with bilateral hypertrophic olivary nucleus degeneration. This we undertook because of the Lees and Lee syndrome phenotype and similarity of this group of patients with the other neurometabolic disorders, and to differentiate between the mitochondrial Lee syndrome and the other patients with the neurometabolic disorders with basal ganglia dysfunction. We analyzed 125 patients with both mitochondrial disorders and other metabolic disorders, and hypertrophic olivary nucleus involvement was seen exclusively in patients with the Lees and Lee-like syndrome of mitochondrial dysfunction. And then we also analyzed the peripheral neuropathy aspect of these genetically characterized patients with mitochondrial disorders and predominant axonal neuropathy. The most common pattern was the axonal neuropathy, and demyelinating neuropathy in SURF1 and the POLG-related disorders had both sensory ataxic neuropathy and axonal neuropathy. And we also analyzed the mitochondrial epilepsy, which is a devastating manifestation of patients with mitochondrial disorders and nightmare for a neurologist who manages the patient. So we tried to correlate whether this genotype and magnetic resonance imaging correlated with the outcome, and divided the patients into 3 groups. Group 1 with the seizure-free or the apparent good outcome, group 2 with the intermittent seizures, and group 3 with uncontrolled seizures. And we found that a fair correlation existed between the outcome of epilepsy, phenotype, genotypes, and MRI findings in patients with mitochondrial disorders. And when we had the results of the exome sequencing, we had this cohort of patients with mitochondrial leukoencephalopathy, who interestingly were, all of them had a diagnosis of ADM at presentation, who developed acute onset of focal deficit, steroid responsiveness, relapsing remitting neurological dysfunction, and on follow-up had a very stable clinical course, and some of them had optic nerve atrophy and some mitochondrial signatures. And the MRI characteristic at diagnosis was confluent. It simulated the ADM, white matter lesions, and confluent white matter lesions with contrast enhancement and diffusion restriction. So we hypothesized whether it reflects the immune activation in mitochondrial leukoencephalopathies, and is it a border zone between the acquired and inherited white matter disorders, and which can have implications for therapy. And analyzed audiological dysfunction in mitochondrial disorders. So Dr. Vandana of speech pathology department she analyzed the audiological manifestations patients with MELA syndrome and 3-4-3 mutation. Even though deafness is an important marker of mitochondrial disorder, the systemic analysis is scarce, and she extended this study to the entire cohort of mitochondrial disorders too. And we did it in-depth analysis of the nuclear or the molecular basis of some of the cohort, like a complex 1 disorders. Dr. Chetan did a DM thesis on this, and then we thought some of the patients who remained, the molecular genetics remained unknown, could have the other dimensions of the mitochondrial function, like mitochondrial dynamics, like fission and fusion, who present with mainly the neuropathic features like a mitochondrial CMT phenotype, like mitofusine mutation. And Dr. Ramesh Sriram from the clinical side, DM neurology trainee, and Shivani from the lab side, they analyzed the standardized and analyzed the mitofusine mutation in a very large cohort of patients with axonal neuropathy. So since the muscle biopsy is invasive and so biomarkers are coming up, in the next step, we thought whether we could bypass the muscle biopsy in any way, and we did a biomarker study with FGF21 and GD15 with both the and compared it with healthy control and neuromuscular control, and you can see that both the biomarkers were clearly elevated in patients with the muscle manifesting mitochondrial disorders compared with healthy control and other neuromuscular control. The GD15 alone was more specific than FGF21 alone, or combined FGF21 and GD15 alone. So we also undertook some patient-oriented studies from the psychiatrist social work. Priya Thomas did this study on quality of life and family burden among children and adults suffering from mitochondrial disorders using structured questionnaires. And this already Dr. Tangaraj has mentioned the contribution of the nuclear and mitochondrial gene mutations in the classical syndromic mitochondrial disorders. And we did other studies in other mitochondrial dysfunction in other studies also. So the traditional approach is the biopsy first from function to gene approach. It's now changed. The genomic has changed the diagnostic paradigm in the diagnostic evaluation in patient with mitochondrial disorders. So it is suspected mitochondrial disorders, biomarkers, and then the exome sequencing and the validate with the biopsy or the invasive procedures. So if there are no candidate variants, and there are various methods to investigate the patients further, like RNA sequencing and other omics approaches. So if you can see, the mitochondrial research lab in NIMHANS has most of the facilities for investigating, to do an in-depth evaluation of the patients who does not have a mitochondrial evident molecular basis, and then that can take it further. So the omics era, recently Dr. Gayathri and team has done the proteomics of a patient with ethylmalonic encephalopathy. We first reported this ethylmalonic encephalopathy with the functional analysis, the clinical features and the functional analysis, and then he did the proteomics in the muscle proteome and found that it alters the mitochondrial function in the human skeletal muscle proteome. And the altered proteins are involved in several pathways and molecular functions, predominantly in the oxidoreductase activity. So this can have the beneficial, this could be beneficial for guiding pharmacological treatment of ethylmalonic encephalopathy, a devastating toxic mitochondrial disorder. So the ongoing research work is that the BlueNet, it is all in-depth studies to study the mitochondrial respiratory function, epigenetic profile, transmitochondrial hybrids for characterization of the novel mitochondrial DNA mutations, and determine mitochondrial morphology, measure the different mitochondrial functions by Dr. Diba Shekhar, the current PhD student of Dr. Gayathri. And so she standardized the being page standardized using control and the skeletal muscle tissue. It's a powerful tool in the diagnosis of patients with suspected mitochondrial disorders. And so the summary is in 1980s, it started with a morphological diagnosis alone for Plopel infant syndrome, then the clinical profiling, mitochondrial DNA sequencing, respiratory chain assays, and in-depth analysis. And the tissue culture, gene expression, proteomics, and hybrid studies have been initiated and is going on. And the next step, the back to the bedside again, will be the drug development, clinical trials, and the prenatal testing and prevention of genetic transmission, and enhancing patient care services with the more diagnostic services. So this Dr. Thankaraj has already, I just copied this in the morning, the International Center for Genomic Medicine in Neuromuscular Disorders, NIMHANS, has been selected with the Dr. Gayathri as the lead PA. And before concluding, I should say that Madam Gayathri, during her very successful career as a myopathologist, clinical scientist, and a teacher, have contributed massively to the growth of the diagnostic services and research in the field of myology, and in particular mitochondrial research, which is going to be helpful for the clinicians and so thousands of patients in the years to come. And Madam, you have also contributed immensely to the academic careers of many of the students and faculty. And as Professor Tani said, I have always found that you were always happy, kind-hearted, and a peaceful person. And I think personally also I should tell that because of this research background, it helped me to procure the grant in Australia, and I could continue the academic career related to mitochondrial mitochondrial disorders here, and my family is greatly indebted to you for this. I wish you have a very enjoyable and relaxed retirement life with your husband and your lovely daughter Kadambari and her family. Thank you very much, and my acknowledgements are due to the entire team of the neuromuscular lab, Anita, and my mentor and professor, and both of them, Dr. Gayatri from the lab side and Professor Tali from the clinical side. They were the masterminds of all this mitochondrial research program, and Gayathri, Dr. Mathu, Dr. Yesha. I should acknowledge everyone, and the CCEMP, Dr. Thankaraj, and the funding bodies, my students, colleagues from the Department of Neurology, and I should also acknowledge my colleagues in the Department of Neurology in Children's Hospital Westmead and Genetic Metabolic Disorder Service and Mito Foundation for supporting me currently. Thank you very much.
Thank you, Dr. Bindu, for sharing such a vast experience in short bit of 30 minutes time. Speaks a lot about your depth, knowledge, and contribution over the 15 years of time to the mitochondrial research. Please keep it up, and thank you very much once again.
Thank you, sir.
Now we have come to the end of this, and I would like to offer immense thanks to all the great speakers of today's program, and thanks to all the chairpersons who have moderated these lectures. Before we go on to the next event, we have a small video session. It's a video message, short video message by some of the colleagues, students, and others who made a
On the occasion of MYOLOGY Symposium, to speak about Dr. Gayathri takes me back to memories of 1983, month of March, when Miss Gayathri and Miss Asha started their professional life in neuropathology in NIMHANS together and continued their journey for 9 years. In my association with her over a past 38 years, I have observed the budding scientist grew up quickly into a full-fledged scientist, guiding many researchers, winning laurels, and publishing her truthful work. She is very simple and an unassuming person, but has a strong will to pursue her work with dedication and commitment. She is always ready to help not only the students of NIMHANS, but also many more from Veterinary College, Agricultural University, and other institutes. There was never a complaint from her in spite of her many hardships she has to face, especially in bringing up her daughter and balancing between professional life and personal life. Her husband Vijay Kumar and daughter Dr. Kadambari are always supportive to her. Hard work is her lifestyle. I always remember her as a person of less words and more work. I wish her good luck.
Namaste. It's a great feeling to talk about Dr. Gayatri. I've been working with her since our students' life. She is a hardworking and highly dedicated lady. Her contribution of biology to the department is quite enormous. Her involvement in forming the new neuromuscular is well appreciated and well recognized. From my bottom of heart, I wish her all the best for her future endeavor. Thank you.
Psychologists use this word association game, which is said to reveal a great deal about the subconscious mind. Just try doing that in our department. If anyone so much as sees, hears, or even reads the word muscle, what instantly comes to mind is Dr. Gayathri. And that is the intensity of association between Dr. Gayathri and myology, which in itself speaks volumes about her passion, her dedication, and mastery in this field. For almost 3 decades of hard labor led to the establishment of the Neuromuscular Lab, which is a referral lab now for the entire country for diagnosis of neuromuscular diseases. Her contribution to the department and to the neuroscience community at large is enormous. She's the person we all go to when we have the slightest doubt in myopathology, and in electron microscopy, her word is final. A teacher such as her is hard to find, difficult to part with, and impossible to forget. We'll miss you, ma'am, more than you can imagine. It has been an honor and a privilege to have learned from you and to have worked with you. We'll really miss that passion, the dedication, and the energy that you infuse into everything that you do. But most importantly, we'll miss that dazzling 100-watt smile that has always lit up all our lives. We won't say goodbye, but wish you all the best and look forward to your continued support in all our endeavors.
Dear Gayatri ma'am, on behalf of all the residents, past and present, we wish to express our deepest gratitude for having been such a wonderful teacher to us. You've always been very encouraging, supportive, and inspired many students through your remarkable energy and spirits. The most memorable moments for all of us has been the penta and decahed reporting, which of course was a combination of terror and fun. Wishing you a very happy and healthy life ahead, ma'am.
Thank you, ma'am.
Madam Ma'am is a marvelous teacher with a genuine smile. Working under her guidance and leadership was the most fulfilling moment of my life. The time that I spent with her learning ultrastructural pathology in electron microscopy lab has driven me to pursue my career in EM. She's a source of inspiration and motivation not only to me but all students. I take this opportunity on behalf of all students to thank her for constant guidance and expert advice and wish her good health and happiness. Thank you.
We have some messages from the FPSI committee. So, I request Dr. Shilpa should show that. These are just a few clips from the NPSI WhatsApp group.
Don't try to read it. I can see it. Just to say that so many people like it. You know, it's okay.
Stopped at the names. I think it stopped at the names. So that we know exactly.
Thank you everyone for those warm wishes and messages. All of us are now eager to listen to Madam Gayatri.
Okay, I have no words whatsoever now because everybody has spoken everything about me and I don't have anything. And I have prepared a small talk for you all, rather to say goodbye and to wish you all the best and also to thank you immensely for everything that you have done. Now, it was quite overwhelming. I really don't have the words now. Anyway, I thought I should start respecting my chairpersons, all of whom were my mentors who have molded me. I owe all my gratitude to Madam Sarla Das for hand-holding me at every step and for being with me. She taught me not only the muscle pathology, but starting from how you orient the tissue, to cut the sections, to how to align the anterior, which is the most important part, and of course, every slide, how we interpret and how we arrive at a diagnosis. I also want to thank her because she has been my mother figure all through. I owe all the clinical knowledge that I have gained from Madam Gauri Devi. I vividly remember every case that I have seen with her, the meticulous way of evaluating the patient and then recording their findings, as well as arriving at a diagnosis. So, Madam, thank you very much for giving me all the clinical knowledge that I have gained from you. I was introduced to Madam by Dr. Shankar, and Dr. Shankar always was very encouraging, very supportive, and no matter what, I go with the questions. He says, don't say no, you can do it. And that is what inspired me to go ahead. And sir, all your critical comments that you had given me all through have been most important for me to better my own career. Dr. Sundaram, I met her first in the NSI conference. That was my maiden presentation. That was in 1987. I presented on the central nuclear myopathy. She came up to me and she said, well done, but then I think you should pursue. So ever since then, she's been my surrogate guide. Madam, thank you very much for being my guide all through. Dr. Tally, sir,
You have been my teacher all through. You are my friend as well as my philosopher. I don't think I want to tell more about you because I have no words for you. I thank all of you for the constant support, encouragement, and most importantly, the freedom that was given to me to rise to this level. I also would like to thank two people who are no more with us. One is Dr. Ram Mohan. For all the electron microscopy that I learned is because of Dr. Ram Mohan. And my great friend, Dr. Anicia. So Dr. Anicia and myself, we started our journey in myology together. I thank all the speakers of today, Professor Gobel, Anthony, Nishino, who has inspired me to pursue my work in myology, my collaborator, Dr. Tangaraj, Dr. Bindu, all the invitees, distinguished pathologists, the neurologists across the country, students, and my dear friends. It's a great pleasure and an honor to be with the stalwarts. What better parting gift can I get other than having a myology symposium? I profusely thank all my colleagues who has painstakingly organized this symposium. Particularly, I would like to thank the mastermind behind this entire symposium, my head, Dr. Yesha. It's all of us. You were the mastermind though. It was a very pleasant surprise to me when I saw the flyer, because all the topics that the speakers chose were very close to my heart. So when I started my journey as a research scholar and then as a PhD scholar, one particular topic which was always fascinating to me was congenital myopathy. And any textbook we open, it is H. Gobel who has written the chapters on the congenital myopathies. And I was so happy to see the flyer and his name first, that he's going to deliver a talk on congenital myopathies. Now, it was then I thought that I must meet this great man someday. And that great day did happen. It was because of Anthony, who I met in the summer school of, he gave me an opportunity to go to summer school of myology, but then I met him in AOMC at Singapore. He saw my poster and instantly he said, you give me your mail and you register for SSM and you are going to come there. So it was during my trip to Paris that I visited Dr. Gobel's lab, and Dr. Gobel took me around his lab. He also gave me all his publications, not just the myology, but also the non-myology, like somebody said, he is also the non-myologist. All the electron microscopy of the inherited metabolic disorders. And I treasure those reprints even to this day, and I have now passed it on to my student, Rashmi. Now, attending SSM, that is Summer School of Myology, changed my perspective. The quantum of research that was going on in the field of neuromuscular disorder boosted me to write projects and contribute further to patient care. Subsequently, Professor Anthony and myself have had several interactions with respect to the patients and their biopsies. I still remember the day when you came to India, you examined a patient. Her name is Josna, whom we had called on biopsy a neurogenic atrophy. I showed you the muscle biopsy and I told you that it is nothing but neurogenic atrophy because there were a lot of grouping of the muscle fibers. But then you said, do you know about this entity called dysferlinopathy? And then you examined the patient and you really taught me how to examine a patient with dysferlinopathy. He just said, you look at the legs, there is atrophy. Now that is the marker for dysferlinopathy. Thank you, Dr. Anthony, for giving me that clinical education on dysferlinopathy. I was also fortunate to meet my examiner, Michelle Fardu, who had evaluated my PhD thesis. And I owe that to you, Dr. Anthony, because you gave me the opportunity to come to Summer School of Myology. Thank you very much. Now, Nishino, I also met Nishino at AOMC, that was in Singapore. He had just finished publishing his cases on Dannon's disease. And I was quite fascinated to see that there is another condition with vacuoles, and that is called as Dannon's disease. So we were discussing about the Dannon's disease, and I was so happy to see that he was talking on Dannon's disease. And the other condition was eczema, which I called it eczema, but I was not confident at all. Sent it across to him, and then he sealed the case for me. Thank you, Dr. Nishino, if you're there. Thank you very much. You also promised after you retire to come to neuromuscular lab at NIMHANS and then do your research work with me. So I'm looking forward for that. So my passion from congenital myopathies to muscular dystrophy slowly drifted towards mitochondrial disorders, because I know that these are very widely prevalent and that all of them do not have those pathological hallmark to give the label as mitochondrial disorders. Now that is when I was introduced to Dr. Thangaraj. So Dr. Thangaraj was generous enough to analyze all of the cases on mitochondrial disorders. Dr. Thangaraj, thank you very much. And he has identified several novel mutations. Now, all those genetic work which Dr. Bindu has presented was because of the work that was done at CCMB, and that formed the base not only for the DM students, but also for the PhD students. Dr. Bindu, of course, I know her from the time she was a student, a very enthusiastic clinician. And after she sees the patient and she sends the biopsy, she calls me up and she says, "Madam, this is this case. And I just have to look at those inclusions to diagnose or give her the final diagnosis." And then she'll come beaming and say, "Madam, that's correct." So Dr. Bindu, I have in the process learned a lot of things about not just the muscle, but also the inherited metabolic disorder. And I have a fond passion towards the inherited metabolic disorders. Thank you. Thank you very much for all that and for being with me. I thank all my mentors, all the speakers for taking the time off to be with me on this day. What better gift can I ask to be amidst the teachers, my colleagues, and all the students who are now with me. I should also place on record NIMHANS. NIMHANS has given me a great opportunity and the freedom to explore myself. It is a great place to work. I'm blessed and privileged to be part of this great institute. I thank all the directors and also the registrars for supporting. There was a constant support from all the registrars and all the directors. I must thank my entire neuropathology family, the faculty, the staff, the technical staff, the attenders, the students, and last but not the least, my husband and my dearest daughter, and of course, my entire family. Long live this great institute. Long live myology. And I will cherish this moment forever. Thank you all so much. Okay, Nari.
Thank you, madam, for such comfortable, nice, warm words. You don't have anything to respond to that. We have come to the last event of today's felicitation and symposium. That is the vote of thanks. And I request Professor Vanis first to propose the vote of thanks.
I think a lot has been said today, and we've reached the end of this wonderful program.
And we are very proud of this. And on behalf of my fellow faculty and the entire neuropathology family, it's a great honor for me to propose this vote of thanks on this occasion of this great symposium that we've had in honor of our dear colleague, Dr. Gayatri, who's going to superannuate this month end. But before I propose this vote of thanks, I thought I should be given a small opportunity to say something about Dr. Gayatri. I know that all of you, many of you have spoken so highly about her and her achievements. And so I promise you I'm going to be very brief about this. I've known Dr. Gayatri for more than 3 decades now, not only as a professional colleague, but as an exceptionally good friend. And we've shared so much in these past years, both on the professional as well as our personal front. And I've really admired her for several of her characters. I've shared an amazing bond with her that I've cherished forever. Her gentle nature and never getting upset about any issues in the department or of the institute issues, her radiant smile that all of you talked about, and more importantly, her wisdom to deal with several matters in the department was what was always amazing to me. I consider her as one of the finest myopathologists in the country with a fantastic knowledge, not only on the pathological or the molecular aspects of myology or the muscle diseases, but also the clinical aspects that she's imparted to so many of us. And she will surely be remembered as a very versatile myopathologist, ultrastructural pathologist, a great scientist who has touched the life of several students and young faculty and shaped their careers. And we saw that lovely messages that came from several members of the Neuropathology Society of India as well, praising her services at NIMHANS. Thank you, Dr. Gayatri, for being there for us, being there with us. And I know that superannuation is going to happen, but our friendship is going to continue for far beyond this superannuation period. And I wish you the very best in your health, your happiness, in your post-retirement life, which is certainly going to be your second innings, because I can see that you're so young at heart and still so passionate about myology and myopathology. So continuing with my vote of thanks message, first of all, my sincere thanks to our beloved director, Professor Gururaj, who allowed us to hold this meeting, this symposium today, and in charge director and registrar, Professor Girimaji, Professor Shekhar Sheshadri, who graced this occasion today. On this incredibly special occasion, we've been honored to have very eminent speakers from across the globe, distinguished faculty from the academia, Professor Gobel, Professor Andini, Professor Nishino, Professor Tangaraj, as well as Dr. Bindu, and all your exceptional talks were really so good that we have all been enriched by your talks. Thank you very much for being there with us today. We're very honored to have our renowned chairpersons from all over the country, Dr. Gayatri's mentors, Dr. Gayatri's teachers, and your wisdom, your knowledge, and your expertise has given that extra spark to today's meeting. Thank you all for that. And I would also, it has been our tribute to host a large audience on this online meeting. I thank each one of the participants for having logged in and also for having attended this symposium. Finally, ladies and gentlemen, no occasion like this can happen overnight. And the wheels started rolling several weeks ago. It required meticulous planning and a bird's eye for details. We've been fortunate to have a team of very motivated and dedicated colleagues in the Department of Neuropathology, very nicely backed by the support from the Department of Biomedical Engineering, Mr. Babish, Mr. Chandrasekhar from the IT cell, Mr. Manjunath, and others from the Mental Health Education Department. They have worked relentlessly behind the scenes to make this event a very memorable one. So thank you, each one of you, for having helped us with this symposium and making it really a memorable symposium. Thank you all once again this evening, and I hope you have a very wonderful and a healthy week ahead. Thank you. Thank you all so much.
Thank you, madam, for the vote of thanks.
Now we should disconnect.
Today's event has created a great memory which will last with us for the lifetime, I'm sure. And I'm wishing everyone a great evening and the week ahead and the year ahead also. Thank you.
Thank you. Thank you all so much. Madam Gauri Devi, Madam Sarla Das. Thank you, Madam Sundaram. Anthony, Tangaraj, Bindu, thank you so much.
Gayatri, all the best. God bless you.
Madam. Thank you so much, Madam.
Look forward to more and more contributions from you still.
Yes, Madam, definitely.
Thank you, Gayatri. It was befitting a symposium, befitting a great person like you. Very, very nicely organized department, and you are the very nice, very nice. Thank you. All
See you in Paris. Sorry. See you in Paris, Gayatri.
Yeah.
Very soon, I hope.
Thank you so much, Anthony.
Always be welcome. Bye-bye.